We are live.
Very good evening to all our respected faculty, dear colleagues, and participants joining us from across the country. On behalf of AIOS, it gives me great pleasure to welcome you all to Guru Sangam, a program where we aim to educate, elevate, and excel. It's envisioned to nurture and strengthen a robust pool of skilled, confident, and future ready ophthalmic educators nationwide. Today we have our session 15, which is a session on retina. And we would like to begin by acknowledging our leaders and AIOS dignitaries, President AIOS Dr. Partha Biswas, Honorary General Secretary AIOS Dr. Santosh Honavar, and Honorary Treasurer Dr. Manoj Chandra Mathur. We have a very distinguished panel of speakers today, which include Dr. Abhishek Gupta from AIMS Kalyani, Dr. Soumya HV from JSS Medical College, Mysore, Dr. Hitashri HR from Bangalore Medical College, Dr. Vipin Rana from Command Hospital, Kolkata, and Dr. Dipanshu Agrawal from Retina Specialty Hospital, Indore. A very warm welcome to all of you, and thank you so much for taking the time out from your busy schedules on this evening. Our expert panel consists of Dr. Aniruddha Maiti from Global Eye Hospital, Dr. Ankur Singh from UCMS Delhi, Dr. Gagan Bhatia from Shroff Eye Center Delhi, and Dr. Thomas Cherian from Little Flower Hospital, Angamali. We welcome you all, sir. The lineup of topics today include diabetic retinopathy, followed by pattern recognition in DME, an algorithmic approach for diagnosis and therapy, studies in diabetic retinopathy and newer treatment modalities, management of subretinal bleed and vitreous hemorrhage. These are going to be covered in great detail, aimed for a better understanding by this very distinguished panel today, followed by expert comments from the panel. It gives me great pleasure to welcome my co-moderator, Dr. Mahima Kaushal, who will be helping me out today, co-moderating the session. And I'm Dr. Megha Banka from Center for Sight, Hyderabad. With this, without any further ado, I now welcome the first speaker, Dr. Abhishek Gupta, to please enlighten us with the topic, Dr. Diabetic retinopathy. Over to you, sir.
Thank you for the kind introduction. And thank you for giving IIS for giving me this opportunity to talk on this topic. Just share my screen. Is my slide visible?
Yes, sir. You can. Yes, sir. Now you're on slideshow. It's visible.
Thank you. So topic for today is diabetic retinopathy. So I have no financial disclosures. So why we should know about diabetic retinopathy? So diabetic retinopathy, it is an eye disease which is caused by chronic hyperglycemia, which ultimately causes retinal microvascular damage and neuroretinal degeneration. This is a very burning topic. Why? Because if untreated, it causes visual impairment and finally blindness. But the major thing to worry is that it is the leading cause of avoidable blindness among working aged individuals globally. So it affects the most economically viable working individuals globally. But the good thing is that by the periodic screening and appropriate therapy, the risk of severe visual loss reduces to less than 5%. So coming to epidemiology, if you see globally around 480 million people is affected by diabetes mellitus. And 1 in 11 adults in the age group of 20 to 80 years is affected by diabetes mellitus. And approximately one third of persons suffering from diabetes, they present with diabetic retinopathy. And among them, 1 in 10 has visual threatening diabetic retinopathy. So overall, globally, if you see, around 160 million people have diabetic retinopathy, and among them, 50 million have vision threatening disease. So this map just shows our country, which is almost the diabetic capital of the world, where around 70 million people is affected from diabetes mellitus. So it is in the red zone, which is accompanied by China and also in North America, in US, where the prevalence of diabetes mellitus is quite high. if you see the map of India, in India, the southern states, especially Kerala, Tamil Nadu, and Karnataka, there the prevalence is around 10 per 100 population, the prevalence of diabetes mellitus. So overall in India, around 70 million people is suffering from diabetes mellitus. And among the 70 million, around 30% will have diabetic retinopathy. So if you see the higher incidence states where diabetes retinopathy is quite prevalent, it is in the Karnataka, Kerala, Tamil Nadu, Andhra, and in the northern states it is in the Punjab. So it is quite a prevalent and it's a pandemic situation in India too. So if you compare the age groups, the people which are suffering from diabetes mellitus in developed countries, it is mostly between 60 to 70 or 60 to 80 years. But in India or in the developing countries, the economically productive age group is suffering from diabetes mellitus. And if untreated, it leads to severe visual loss and blindness. So this is a very alarming situation where the economically viable age group will further land in severe vision loss. So early detection and appropriate treatment is the demand of now. So considering the prevalence, the duration of diabetes is also a major development for diabetic retinopathy. With longer duration of diabetes mellitus, there is an increasing incidence of diabetic retinopathy. So if we see in people suffering from diabetes mellitus type 1, 25% will have retinopathy after 5 years, which will increase to 60% after 10 years, and up to 80% after 15 years. So a person having uncontrolled diabetes mellitus for quite a long period of time will also exhibit severe grade of retinopathy with progress in time. But with adequate glycemic control, there leads to far reduction in the development of any retinopathy. So as you can see, if there is glycemic control in type 1 diabetes mellitus, it will cause 70% reduction in the development of retinopathy. So a target HbA1c level of 7% or lower is recommended for most patients. And with control of coexisting hypertension or hyperlipidemia, the prevalence of diabetic retinopathy reduces further. There are also genetic factors which play a role in development of diabetic retinopathy, because in type 1 diabetes mellitus, heritability estimates is around 25 to 50%. But also in this heritable status, there is variation in epigenetic susceptibility, where two individuals of diabetes mellitus suffering from diabetic retinopathy show different levels of diabetic retinopathy progression. So even though there are genetic factors, but still heterogeneity exists in epigenetic susceptibility, which further dictates the development of severe grades of diabetic retinopathy. So coming to the pathogenesis of diabetic retinopathy, it is typically multifactorial. So chronic elevation of blood sugar causes advanced glycation end products production, which causes protein kinase C activation. Finally, all these pathways causes oxidative stress and a low-grade inflammation in the body. So with this continuous low-grade inflammation, multiple chemokines and inflammatory factors are released, such as TNF-alpha, interleukin beta, interleukin 6, INOS, ICAM, these molecules. So these molecules further, they cause microglial and monocyte activation, which causes leukocytosis and further lead to pericyte loss. So pericytes, they are the framework of the smaller blood vessels. So with pericyte loss and basement membrane thickening, the architecture of the blood vessels collapse and they get occluded. So with occlusion of the blood vessels, particularly the retinal blood vessels, there is retinal hypoperfusion. So once there is hypoperfusion, it causes release of VEGF molecule, VEGF factor. This vascular endothelial growth factor, it further causes blood retinal barrier breakdown and increases the permeability of the blood vessels, which leads to diabetic macular edema. And the hypoperfusion caused by the occlusion of the blood vessels causes local ischemia, and with ischemia there is neovascularization. So overall, there is inflammatory pathway which causes release of multiple chemokines, which causes pericyte loss, vascular occlusion, ischemia, neovascularization, And then there is vascular hyperpermeability, which is maintained by the VEGF factor. Apart from this, there is also neuroretinal degeneration, which causes the loss of the retinal nerve fiber layer and the ganglion cell layer, and finally results in retinal thinning, which is often seen on OCT when we measure the RNFL layer and the ganglion cell thickness. So overall, the pathogenesis is multifactorial with multiple pathways culminating finally in proliferative diabetic retinopathy or diabetic macular edema, which ultimately leads to severe vision loss. So this is one of the histologically stained tissues where you can see this is the microglial cell. This is the normal microglial cell where it has long dendrites and a normal or a small cell body. But this is a severe diabetic retinopathy retina where you can see with development of severe diabetic retinopathy, the dendrites over here, they have become smaller and the cell body has enlarged, the microglial cells. And here in the normal retina, the microglial cells is present in the superficial retina, but because of continued inflammation and the multiple inflammatory chemokines which is released, these glial cells are distributed throughout the retina, ultimately causing neuronal degeneration and increased vascular permeability and vascular occlusion. So coming to diabetic retinopathy, how do we diagnose diabetic retinopathy? So non-proliferative diabetic retinopathy, it is the classical signs present in the retina which we see are microaneurysms, intraretinal hemorrhages, venous changes, intraretinal microvascular abnormalities, and cotton wool spots. So we will see each sign one by one. This is a normal fundus where we can see multiple small red dots scattered throughout the posterior pole. So these are microaneurysms which are actually, they are capillary outpouching. So this is a normal capillary and you see there is a saccular dilatation over here, the outpouching of the capillaries. So as previously told that there is basement membrane thickening and pericyte loss. So pericyte is the actual structural framework of the blood vessel. So with pericyte loss, the structural integrity is lost of the smaller capillaries and arterioles, and there are multiple outpouchings which is seen. So these outpouchings are finally, here is the site from where the retinal blood, the vascular compartment leaks outside and comes into the retinal interstitium. So here you can see on a histologically stained slide where there are numerous pink dots which characterizes the microaneurysms, which is better seen on fundus fluorescein angiography as multiple small white dots less than 50 microns. And if you follow this up in the later stages, so which is showing actually decay. So these are so in the early stage, they are seen as multiple bright white spots, which finally exhibit a halo around them. So here you can see a halo around the microaneurysms, which signifies leakage from these microaneurysms. The second sign is dot and blot hemorrhages. So with the breakdown of the blood retinal barrier, the intravascular compartment leaks out. So blood extravasates into the retinal interstitium, and here they actually line up, end up in the inner nuclear layer in the form of dot and blot hemorrhages. So you so these are the dot hemorrhages, and the larger dot hemorrhages are the blot hemorrhages. So if you see on OCT, so they are particularly present in the inner plexiform layer. And here, so sometimes small dot hemorrhages can be confused with microaneurysms. So here these are the microaneurysms which are very small red dots, and the larger red dots are the dot hemorrhages. And on fundus fluorescein angiography, if you compare, so the microaneurysms will be seen as small white dots, while the dot hemorrhages will be seen as blocked fluorescence. So these are the blocked fluorescence from the hemorrhages, and these are the microaneurysms. Sometimes you can also see the flame-shaped hemorrhages. So flame-shaped hemorrhages, they are actually streak-shaped hemorrhages. They will be radially oriented in a circumferential pattern, and they will be present in the superficial retinal layer. So mostly it is seen when there is concomitant hypertension along with diabetic retinopathy. So flame-shaped hemorrhages are also present. And if there is abundance of flame-shaped hemorrhages and less of dot plot hemorrhages, then the patient should also be checked for hypertensive retinopathy. He should also blood pressure should also be checked. The next sign is presence of cotton wool spots. So as I have told already that there is occlusion of the smaller blood vessels. So these occlusion of the smaller blood vessels causes axonal infarcts in the retinal nerve fiber layer. So actually, so these axonal infarcts are actually seen as whitish spots in the superficial retina. So these are nothing but these are the axonal infarcts where in the retinal nerve fiber layer the flow of exoplasm has stopped and it has caused swelling of that part, which is actually seen as a diffuse white spots known as cotton wool spots. Then if there is severe diabetic retinopathy and there is severe ischemia, then the larger blood vessels are also affected, and then the venous changes are seen in the form of venous bleeding, where we can see a dilated retinal vein with constriction and alternate constriction and dilatation. So here we can see a dilated retinal vein which shows constriction, then dilatation, then again focal constriction, then again focal dilatation, and so on. So this gives a beaded appearance, which is seen as venous bleeding, or it can also exhibit venous looping. So here we see a retinal blood vessel which is showing a looping or bending. So these venous changes like venous bleeding and venous looping is seen generally in advanced form of diabetic retinopathy. So with continued non-perfusion, what happens because of retinal ischemia? Directly arteriovenous shunts are formed in the intraretinal layers, which is seen in the form of intraretinal microvascular anomalies. So intraretinal microvascular anomalies, they are actually vascular shunts, which is seen in the intraretinal layer. Sometimes it gets, and when it gets confused with neovascularization. So neovascularization will actually be present above the surface of the retina, above the hilum, and it grows into the vitreous. And anything in the intraretinal layer will be seen as irmas. And if we do a fluorescein angiography, then neovascularization will leak profusely, while irmas will not show any leakage. So once we are familiar with all the signs of the common clinical signs of non-diabetic retinopathy, then comes the need to grade the diabetic retinopathy. So as we know, the diabetic retinopathy can range from mild to moderate to severe non-diabetic retinopathy. And in order to prognosticate the patient, to line up the follow-up visit, and to help us in the management protocol, the American Academy of Ophthalmology have adopted an international clinical diabetic retinopathy scale, and they have graded diabetic retinopathy from no retinopathy to severe non-proliferative diabetic retinopathy. So, which we must know about this because this is very important in the management of the patients. So, which is very easy actually. A patient suffering from mild NPDR will show only microaneurysms, only microaneurysms or few dot hemorrhages, and then we can classify him as mild NPDR. For severe NPDR, we all know about the 4-2-1 rule, where there is 20 hemorrhages in each of the 4 quadrants, or venous bleeding in 2 quadrants, or irmas in 1 quadrant. So if any of the following feature is seen, then we classify him as severe NPDR. And anything between mild NPDR and severe NPDR, more than mild NPDR but less than severe NPDR, is characterized as moderate NPDR. So here we see 3 fundus pictures. So if we divide this picture into 4 quadrants, so here in the first picture we can see there are only few microaneurysms, rest of the retina is normal. In the second one, or let's go to the third picture. Here we can see, if we follow the 4-2-1 rule, so we have divided these are the 4 quadrants, and in each quadrant you can see there are multiple hemorrhages, which is more than 20. So if one of the criteria is there, then this is classified as severe NPDR. Coming to the middle picture here, you can see there are hemorrhages in all four quadrants, but it is less than 20. So it is not matching the criteria of severe NPDR. So this is moderate NPDR. So, and if in the severe NPDR, if two criteria are matching, then it is called as very severe NPDR. So this was the grading of diabetic retinopathy. But the major cause of vision loss in diabetic retinopathy is diabetic macular edema, and it can be present in any stage of diabetic retinopathy. It can be present in mild, it can be present in moderate, or it can be present in severe NPDR. So American Academy of Ophthalmology has given a fundoscopic classification of diabetic macular edema, a very simple classification where just on a 90D, a proper 90D examination, if you do not appreciate any retinal thickening or there is absence of hard exudates in the posterior pole, then probably DME might be absent. But if you see any retinal thickening or hard exudates in the posterior pole, then diabetic macular edema might be present. So if diabetic macular edema is present, then again you can classify it ophthalmoscopically as mild, moderate, or severe DME. Mild DME is only some retinal thickening or hard exudate, but it is distant from the macula. So any hard exudate which is away from the macula might be having mild DME. While moderate DME, there is hard exudate or retinal thickening which is approaching towards the center of macula, but it is not involving the center. So it is threatening to come towards the center, but is away from the center. So it is characterized as moderate DME. And any retinal thickening or hard exudates in the center of the macula is known as severe, classified as severe DME. So whenever we see a patient, so on 90D examination, we first of all we must try to classify it as NPDR or PDR. If it is NPDR, so whether it is mild, moderate, or severe, and if there is NPDR, then we should also try to classify whether it is DME or not, and if it is, then mild, moderate, or severe DME. So once we classify it, so classification is also important for following up of the patient, so which is very much essential because if there is no control of blood sugar, then a mild NPDR can progress to moderate or severe NPDR. So they have also given a minimum follow-up routine based on the baseline diagnosis. So type 1 patient, the first recommendation for first examination is within 3 to 5 years of diagnosis of diabetes. So whenever a type 1 diabetes mellitus is diagnosed, he should undergo a diabetic retinopathy screening within 3 to 5 years of diagnosis. A type 2 diabetes mellitus, whenever at the instance of diagnosis, he must undergo diabetic retinopathy screening at the time of diagnosis only. And a pregnant lady before conception or during the first trimester should undergo first examination for diabetic retinopathy screening. So, and once a diabetic retinopathy screening is done and a proper diagnosis is made, so if it is mild NPDR, then that person can be followed up after 6 months to 8 months. If it is moderate, then 3 to 6 months. And if it is severe, then every 1 to 2 months, he must be followed up regularly for development of any complications or regression. So NPDR, if severe NPDR is not controlled, then it progresses into proliferative diabetic retinopathy or PDR. And new vessel formation or neovascularization is the hallmark of proliferative diabetic retinopathy. So American Academy of Ophthalmology, they have also classified PDR into early PDR and high-risk PDR. So here we see the disc, and there is profuse fine radiating vessels arranged, which is radiating in all directions. Very fine interlacing vessels, which has formed over the disc. And in this picture, we see these vessels, they have crossed the disc and they have come over the retina. While here, these fine vessels, this is present in the retina along the inferotemporal arcade. So actually, these are the neovascularization which characterizes the development of proliferative diabetic retinopathy. So any high risk PDR, very simple to remember. If the NVD, this is the vessel over the disc, is known as NVD. If it is more than half disc area, then any NVD which is more than half disc area will be known as high risk PDR, or any NVE which is more than one third disc area will be characterized as high risk PDR. And any vitreous hemorrhage with any NVD and NVE will be characterized as high risk PDR. And this is actually where all the trouble begins, where a person from normal vision can actually go to irreversible loss of vision. So first actually what happens, so the first irmas are formed, they are in the intraretinal compartment, then they come over the ILM where they form the NVE. This NVE then grows along first tangentially across the retina, and then it comes into the vitreous through the vitreous scaffold. So once it enters the vitreous scaffold, then the fibrous tissue starts growing around it. So here you see these are all fragile blood vessels where there is no trace of fibrous tissue. But here you see these are fragile blood vessels where whitish tissue have started coming over it. So now it is fibrovascular proliferation, which starts happening over the retina and into the vitreous. And this is what is the harbinger of the development of advanced diabetic eye disease. So this is how neovascularization looks on FFA, where in the early phase you can the vessels are highlighted, and then they start leaking from the mid phase to the late phase, where they leak exuberantly. So this is how a neovessel will leak on FFA, thus differentiating it from irmas which do not leak. So this is another case of high risk PDR, where we can see a neovascular front above the disc, which is a neovascularization elsewhere, and this is clearly more than one third of disc area. So this goes into the HR PDR category. So this is only neovascularization, and now there is fibrous tissue along the blood vessels also. So this is now fibrovascular proliferation. So if it is not checked now also, then finally this fibrovascular proliferation will start extending. So here it is in one quadrant. Now it has grown exuberantly. Now it is going into the second quadrant. Now this fibrovascularization has encompassed all the four quadrants. So actually what happens with the development of fibrovascular proliferation, when vitreous contracts, the force is transmitted through this fibrovascular tissue into the retina, and now the retina gets pulled up. So finally it causes tractional retinal detachment, as you can see here. So a simple neovascularization finally leads to tractional retinal detachment. So this was one spectrum of neovascularization. Other spectrum of high-risk PDR is presence of any amount of vitreous hemorrhage with any extent of neovascular. Here in neovascularization. So this is vitreous hemorrhage along with neovessels over the disc, which can be mild, or it can also manifest in the form of pre-retinal hemorrhages. So if this is not controlled, then this can exceed, and finally it can cause a large subhyaloid hemorrhage, or a total vitreous hemorrhage, or total subhyaloid hemorrhage, causing severe vision loss. So up till now also, the disease is still, with surgery and with laser, the disease can still be checked. But even if now it is not checked, then finally, because of continued ischemia and severe retinal neovascularization, finally iris neovascularization will ensure, which will first neovascularization of the iris will happen, which will lead to neovascularization of the angle and cause angle closure. This is synechial closure of the angle, where finally when all 360-degree angle closure will happen, it will cause sustained elevation of intraocular pressure and will result in end-stage glaucoma. So a simple So this is the whole spectrum in a nutshell, where a patient suffering from mild NPDR characterized by only microaneurysms can go into severe NPDR characterized by 4-2-1 rule. If not checked, then go to early PDR. If not, then high risk PDR. Again not, then high risk PDR leading to tractional retinal detachment or vitreous hemorrhage. Even if not controlled, then will finally cause neovascularization of the iris, angle, and advanced, finally, neovascular glaucoma. So once neovascular glaucoma develops, this is an irreversible loss of blindness, which cannot be reversed back. And finally, that now the methods are only temporizing method or rehabilitative methods only, which can be proposed. So actually, so we see this spectrum where a person from a mild case can progress to very advanced diabetic eye disease. But the good thing is that with proper screening and proper treatment, all these symptoms can be reversed back and vision can be restored to almost near normal. So with this backdrop, once a patient develops diabetes, retina is the most commonly affected tissue, but there are other ocular tissues also which is affected, which we should not forget. So there is diabetic neurotrophic keratopathy. So the cornea is also affected. Why? Because the cornea, it is innervated by sensory, it has got sensory nerve endings, and as I have told, there is also neuronal degeneration. So the sensory nerve endings also start degenerating, and the corneal epithelium actually is maintained by the trophic factors released by the sensory nerve endings. So a patient can have recurrent epithelial erosions. Studies have also shown that patients suffering from diabetic retinopathy also have primary open angle glaucoma and neovascular glaucoma, as we have already seen. So chronic hyperglycemia, it also affects the lens, which can lead to development of cortical cataract and posterior subcapsular cataract. And when these patients undergo cataract surgery, so they are at high risk of development of post-operative macular edema. So any diabetic patients, whenever taken up for cataract surgery, a proper retinal examination has to be done. The staging has to be done. It has to be established whether diabetic macular edema is present or not. And all these parameters should be adequately controlled before taking up a patient for cataract surgery to prevent post-op macular edema. And also, if there is a complicated cataract surgery, then the post-op inflammation actually causes increase in the progression of diabetic retinopathy. So mild can become moderate or severe diabetic retinopathy. Also, when after cataract surgery, when spectacles are prescribed, so patients should have adequate glycemic control. So a fluctuation of sugar in his blood actually affects the lens also. So whenever the sugar level is high, actually it causes a myopic shift. And if in that case, if the patient gets a prescription of spectacles and he makes a new spectacle for him, and when his blood sugar is controlled, then myopic shift goes into hyperopic shift. So from then he will not accept those spectacles. So any person who is on fluctuating blood sugar should actually he should be maintained on a good glycemic control before prescription of spectacles. And as we know that because of increased sugar and hypertension, a patient is also prone to development of NAION, especially if his disc is at risk. Diabetic papillopathy also manifests, which can cause optic atrophy. And also, since we should not forget that it is not the only retina which is there where it is suffering from non-perfusion. Actually, there is brain, kidney also where the blood vessels are affected because of chronic hyperglycemia. So a brain can also manifest microinfarcts, and it can cause ophthalmoplegia because of palsy of cranial nerve 3rd and cranial nerve 6th. So patient can present with varying degree of ptosis, diplopia, ipsilateral headache, double vision, anything because of cranial nerve 3rd and 6th palsy. So eye should be examined as a whole rather than only the retina being the focus. So this was all the clinical examination which is done, and the clinical examination is confirmed by certain investigations, and the most common investigation which is performed is OCT. So earlier we have seen the ophthalmoscopic classification of macular edema, which is confirmed on OCT. So on OCT, there can be different patterns of diabetic macular edema. So most commonly, which is seen is cystoid macular edema, where there are multiple cysts in the intraretinal layers. Sometimes the whole retina can be diffusely elevated, or it will be diffusely thickened, which is manifested in the form of diffuse spongiform retinal thickening. Sometimes only the subretinal fluid is collected in the form of serous macular detachment. So the maximal water accumulation is seen in the subretinal compartment. And sometimes you can see the mixed type where intraretinal cysts and subretinal fluid coexists. And also, because there are certain because of changes in the vitreomacular interface, retinal cysts can be accompanied by taut posterior haloid or vitreomacular adhesions. Also, since the advent of OCT is actually the most commonly performed test to confirm a diabetic macular edema, and all the treatment is based upon presence or absence of intraretinal fluid. So OCT classification of diabetic macular edema is center involving or non-center involving diabetic macular edema, where fluid gets accumulated beneath the fovea, thus elevating the fovea and loss of the foveal concavity. So this is center involving, and sometimes fluid can be seen in the parafoveal or paramacular spaces, which is actually not beneath the center, but rather in the sides of the fovea. So this is, you can see a cyst over here, which is over one side of the fovea. And in this picture also, you can see a cyst, which is actually encroaching towards the fovea. So these are all non-center involving edema, and this is center involving diabetic macular edema. And actually, we should try to classify diabetic macular edema like this also. Why? Because actually it helps us in the treatment strategy, which we will see later. With the advent also, it has started giving, so we can actually see all these. So retina has the superficial and deep capillary plexus, and with the advent of Octa, these both can be visualized very elegantly. So here you can see the superficial vascular plexus, the deep vascular plexus. So actually in FFA, what we see is only the superficial vascular plexus, where there is in macular ischemia, where there is increase in the area of the foveal avascular zone and distortion of the foveal avascular, which is very non-invasively seen in Octa. So here you can see the superficial vascular plexus, which is enlarged and distorted. But the main thing is, which is not visualized in FFA, is the deep vascular plexus. We can see the deep vascular plexus is also enlarged and distorted.
Very sorry to interrupt, sir. I must ask you to conclude quickly, so we have time for discussion as well.
Okay. So next investigation is the fluorescein angiography. So fluorescein angiography also helps us in the management. So here, if you see this patient, this is mostly, we can categorize as moderate or severe NPDR. But if we do an FFA, we can see multiple leakages throughout the retina. So these are all actually all NVEs which we see. So now after FFA, which is missed on fundoscopic examination, so this is characterized as high risk PDR. Similarly, this patient of moderate NPDR with multiple injections, and still there is intraretinal fluid and subretinal fluid. So if we do FFA, then we see there are multiple microaneurysms which are leaking. So we can actually, even after multiple anti-VEGF injections, we can opt for individual laser of these microaneurysms, which can lead to resolution of macular edema. And FFA can show the focal, whether the microaneurysm leak is, whether it is focal in nature or whether it is diffuse, which can actually help in the plan of focal laser. Finally, I will end up with ultrasound B-scan, the last investigation. So ultrasound B-scan is done in cases of vitreous hemorrhage or in advanced diabetic eye disease, where, so this is vitreous hemorrhage, which here you can see the opacities in this in the vitreous with underlying retina which is intact. This is the vitreous hemorrhage. This is the subhemorrhoid hemorrhage. The disc and macula which is normal. And in this case, where there is advanced tractional retinal detachment, here you can actually see the amount of the extent of attachment of the fibrovascular proliferation to the underlying retina. So actually B-scan also helps before surgery to plan the adequate approach and the vitrectomy strategies. So, okay, I will conclude over here. The rest is the treatment part, which I think will be taken up by the next speakers. Thank you.
Thank you, Dr. Abhishek, sir, for that excellent, insightful talk on diabetic retinopathy. The clinical images and the B-scan images which you showed were especially helpful in correlating theory with the actual fundus findings. Really well presented. I would now like to invite our expert panel to share their thoughts and key takeaways from this talk. Dr. Anirudh Methi, sir, would you like to chime in?
Abhishek, it was an excellent presentation. I just wanted to add a few associations that is very much related to the progression of the diabetic retinopathy. You have already mentioned the hypertension. Along with the hypertension, I think two things we need to keep in mind. That is the lipid profile, that is hyperlipidemia actually causes the progression of diabetic retinopathy. And I think the nephropathy is one which actually guides the progression of the diabetic retinopathy if there is lower eGFR or the ACR ratio if it is high. And we need to actually advise this stage for our patients so we can get an idea about the nephropathy. And if it is worsened, like if the renal profile is bad, there is a huge progression of diabetic retinopathy. And in fact, our treatment also depends on the value of the eGFR and the ACR. So I think these two things I would like to add in your presentation. And I think the macular edema classification, what you have described is absolutely fine. But more practical way is the center involving and non-center involving because of the treatment actually differs on that.
Yes, sir.
Otherwise, it is an excellent one.
Thank you, sir.
Thank you, sir.
Dr. Thomas Cherian, sir, would you like to add?
Yeah, Abhishek, a good overview of diabetic retinopathy. In fact, when you go out to the community and talk about diabetic retinopathy, we now use a term called sight-threatening diabetic retinopathy or vision-threatening diabetic retinopathy. It's slightly different from our classification, the ETDRS classification, because sight-threatening diabetic retinopathy includes both PDR as well as DME. And this is where we need an early intervention. That is why we have this type of classification when we go out to the community and talk about diabetic retinopathy. And as Mighty Sir said, when we take a history of diabetic retinopathy patients, in addition to the glycemic control, hypertension, and lipidemia, and also look at anemia and nephropathy, because these are all the confounding factors which could add on to a diabetic macular edema, not necessarily a PDR. Once it's a PDR and you go all out and ablate. But once it's a diabetic macular edema, always look for these factors before you start treatment, because these could also aid in controlling your diabetic macular edema. Also take a drug history, whether the patient is on insulin, what type of oral hypoglycemics is he on. So that also adds on, because certain type of oral hypoglycemics, the glitazones, pioglitazone, they add on to diabetic macular edema, and it would be a good idea to talk to your diabetologist and get the drug changed if the patient is on glitazone and the patient has a significant diabetic macular edema. Otherwise, your talk was very good. It was a good overview of diabetic retinopathy. Thank you.
Thank you, sir.
Dr. Gagan Bhatia, sir?
Yeah, hi. So I think Dr. Anirudh and Dr. Thomas have already kind of elucidated the metabolic control, everything. So I won't go to that, and I totally agree to what they've said. I think in diabetic retinopathy, one of the major changes which have come around, and I think Abhishek has put all these changes very well. All the signs he's shown very well. But I think one of the changes that has really come around in diabetic retinopathy is imaging. So I think the right imaging tools and the right time is extremely important. I think we've moved on from the 7 Amsler's grid pattern that we used to study earlier for diabetic retinopathy and moved to wide field imaging. I think as far as fluorescent angiography is concerned, I think that still stays the main tool for imaging with, as I see with our, my fellows and postgraduates, I think they're more erring towards an Octa because they feel that Octa is better. But I still feel that, what Dr. Abhishek has shown, FFA is still the main tool to kind of prognosticate and, see the progression of diabetic retinopathy, whereas Octa would probably be helpful in cases where, because you have associated nephropathy, and that's a big debate whether you want to use the fluorescein dye or not. But if there is no clearance, then I think Octa does play a good role. The second thing is that I think, which I think you did show, but I think at certain stages, I feel that OCT again, does play an important role. Yes, we do say that FFA is not very good for, I mean, it does not really tell us the macular edema because you have those diffuse leakages that are present and Octa is better. But we need to also realize that Octa can be misleading because if you have CME present over there, it's actually it's a false representation of absence of vessel than actually macular ischemia. So one other important part, which I think I would like to just add, which imaging tells us is, macular ischemia, which is there, which FFA, still tells us a lot about before we intervene for surgical intervention or anything like that. So rest, as far as screening is concerned, I think again we have handheld cameras and everything, and we have a lot of reporting centers now which are doing reporting of diabetic retinopathy screening. So I think knowing these signs of diabetic retinopathy and staging of diabetic retinopathy is extremely important. And yes, when we come to clinical treatment, I think classifying them as Dr. Mehti said, as central involving and non-central involving is the nowadays the concern. But yes, I think at a PG level or a fellow level, I think the basic modalities and the basic classifications need to be very well read. So otherwise, I think it's a huge topic, and I don't think any number of minutes or hours can really justify it. And I think it's very well covered. Thank you.
Thank you, sir.
Ankur sir, would you
Uh,
like to add?
Yes, very, very nicely summed up the diabetic retinopathy. Everything was covered, and our expert panel has covered almost every point. All I want to say is that FFA, just as Dr. Gagan said, is still holds its value. So baseline FFA is something that we should always go for before going for an OCT angio on the follow-ups. And second thing is just for the fellows to know, when we talk about NVD, NVD is also a neovascularization within one disc diameter of the disc. So any neovascularization, which part of which is within the one disc diameter, is also NVD. Why that is important is the patient, for the students to classify it as an HRC. So when they see one third of these vessels over and around the disc, that's also an HRC. So if you have and second thing is this, in broadly, for to understand for the treatment, because HRC means early PRP. So they have to understand if they see vitreous hemorrhage, subhyaloid hemorrhage or vitreous hemorrhage, it's usually associated with half this size NV. So if you see a vitreous hemorrhage, this means the patient has, or subhyaloid hemorrhage, the patient has HRC and needs to be taken for treatment. I think excellent talk. I think you have covered everything, and which whatever things were required has been covered by our experts. Thank you.
Thank you, sir.
Thank you, sir. Thank you to our panelists for their valuable additions. And with that, we'll now move ahead. It is my pleasure to invite our next speaker, Dr. Soumya HV, for her talk on patterns recognition in diabetic macular edema, an algorithmic approach for diagnosis and therapy. Over to you, ma'am. Please go ahead and share your screen.
Are my slides visible?
Yes, ma'am, perfectly visible. Yeah.
Thank you, Dr. Mahima, for your kind introduction, and a very good evening, everyone. And at the outset, I would like to thank AIOS leadership as well as Dr. Santosh Navarsa, the expert panel, and the moderators for having me a part of this Teach Fest initiative, AIOS GuruSangam. platform for learning and sharing knowledge. And my topic today would be pattern recognition in diabetic macular edema, which would help us for an algorithmic approach for its diagnosis and therapy. No financial disclosures. So my objectives of today's presentation would be the introduction of the topic, the classification systems, triaging of diabetic macular edema, especially with regards to its patterns, phenotypes and their clinical implications, recognition of the resistant biomarkers and targeted therapy, and the role of systemic factors, which our esteemed expert panel just now threw light upon. Now, diabetic retinopathy, as all of us know, is one of the most common microvascular complications, important cause of visual impairment in the working age group. Now, prevalence of any macular edema among diabetics is 8.9%, and that of referable diabetes mellitus is about 2.4%. This can coexist with any severity level of retinopathy. One of the leading cause of sight-threatening diabetic retinopathy in diabetic patients, the other being proliferative diabetic retinopathy. These patients could be the most challenging patient to care for in our retina clinic. The pathophysiology would definitely have three important components here. The hyperglycemia, which would alter the blood retinal barrier, which could be outer as well as inner blood retinal barrier, resulting in increase in fluid influx and decrease in the functions of the Muller cells, RPE, resulting in diabetic macular edema. Now, the hypoxia would induce upregulation of the VEGF, which plays a key role in the alteration of the blood retinal barrier and also inflammation. So, these three factors would definitely contribute in the pathophysiology of diabetic macular edema. This image shows an overview of how a macular edema could occur and what are all the attributes to that would result in a diabetic macular edema. The most common would be hyperglycemia, along with the presence of comorbid conditions like hyperlipidemia, hypertension. Hyperglycemia results in drainage dysfunction, inflammation, blood retinal barrier breakdown, oxidative stress and neurodegeneration, as told by Dr. Abhishek, which results in, especially when we are looking into the ganglion cell IPL as well as the RNFL thickness. Now, two forms of edema could definitely occur, which could be intracellular or extracellular. Now, the intracellular is basically cytotoxic edema. Extracellular is basically the vasogenic. Extracellular results in it's mainly because of the blood retinal barrier breakdown, whereas intracellular could be hypoglycemia induced abnormalities, the abnormalities of RPE cells, Muller cells and the retinal neurons. Now, what is the role of VEGF in diabetic macular edema? As discussed, hyperglycemia, which results in accumulation of advanced glycation in products, there would be protein kinase C overaction. And all these things would be, and hypoxia would result in upregulation of vascular endothelial growth factor, which results in the blood retinal barrier disruption and resulting in diabetic macular edema. Now, the most important thing, how do we evaluate a patient with diabetic macular edema? A very important part here is a detailed history, which could never be overemphasized, especially with regards to the drugs, the systemic emphasis, ocular and systemic history, emphasis on the type of oral hypoglycemic agents used, other medications, and detailed clinical examination, fundus examination with 78, 90 diopters and 90D lenses and indirect ophthalmoscopy, and the role of imaging, use of fundus photo, serial fundus photo, so that we can actually gauge the severity of the disease, and fluorescein angiography and OCT and as well as OCTA. Now, coming to the history wise, the duration, especially important is the duration of diabetes, the control of hypertension, hyperglycemia and hyperlipidemia should be asked. The presence of anemia and renal disease should be noted. A detailed drug history is essential, especially like what Dr. Thomas Cherian sir said, thiazolidinediones, use of other drugs. That's very, very important, because resistant cases of diabetic macular edema will always, we'll have to go back to the history and see what drugs are being used. And history of recent surgical procedures also is to be noted. The first step, as told earlier, a thorough clinical examination and performing OCT and fluorescein angiography unless it is contraindicated. We all know that the indications of FFA have really changed nowadays, but as one of the most important or a direct, we can actually know the health of the vessels directly with the help of fluorescein angiography. So the only way to assess directly assess the vessel leakage, it's a functional correlate to the anatomic microstructural changes that could be visualized on OCT and OCTA. especially with regard to the ultra wide field imaging and FA. If there are any presence of peripheral retinal findings, that could definitely correlate with diabetic macular edema. Most important to differentiate ischemic versus non-ischemic diabetic macular edema, especially in featureless retina with poor best corrected visual acuity. If the vision loss is out of proportionate to the fundus findings, definitely there is an indication to do a fluorescein angiogram, because we need to rule out any macular ischemia, so that helps us definitely in prognosticating the treatment outcomes, as well as it helps us to counsel the patient. Now, what are the types of or what are the pattern recognition that which we could see in FFA? We have types of leakage that could be focal edema, a diffuse edema, mixed, which is most often, and ischemic edema sometimes. Ischemic edema due to ischemia of the macular area. Now, focal is mainly because of leaking microaneurysms. They benefit directly from focal macular laser. Diffuse edema is characterized by poorly demarcated areas of capillary leakage. Mixed is a combination of focal as well as diffuse leakage. Now, in an ischemic macular edema, presence of macular capillary non-perfusion and enlarged FAZ are the signs of macular ischemia. Now, an algorithm to treat diabetic macular edema as suggested by the pictures, but I would go into the detail into this slide. Let us dwell upon this slide for a minute so that we would understand what patterns and what could be generally the treatment of choice that is used here. Now, in the presence of a focal diabetic macular edema, there is focal hyperfluorescent leaks from microaneurysms. This signifies a localized blood retinal barrier breakdown. So, the treatment of choice, focal or grid laser plus or minus anti-VEGF. In a diffuse macular edema, it's a diffuse, ill-defined, poorly demarcated areas. So, this is mainly by the VEGF mediated vascular permeability. The anti-VEGFs would be the first line of choice here. And presence of cystoid macular edema, where we find a petaloid pooling of dye in the late phases. So this clinical significance is intraretinal cyst formation here, anti-VEGF plus or minus steroids, and ischemic DME, which is characterized by enlarged and altered FAZ, CNP areas and minimal leakage. So the clinical significance here is poor visual prognosis, and avoid the foveal lasers, and cautious anti-VEGF use should be thought of here. And a mixed DME where there could be focal leaks as well as diffuse leakage. So a combined pathology, it could be because of hyperglycemia induced or a VEGF upregulation, anti-VEGF, and more, again a targeted laser can be used here. And peripheral ischemia with DME, when I told about the ultra wide field imaging, and FA, here peripheral non-perfusion with macular leakage. So this also suggests a VEGF drive. So anti-VEGF plus or minus peripheral laser can be a treatment of choice. And chronic refractory DME, persistent leakage despite treatment, the inflammatory component plays a great role here. And intravitreal steroids could be the treatment of choice, but most important is here a systemic factors definitely have to be looked into when we are dealing with a patient of chronic or refractory DME. So, continuing the FFA, the role of FFA, baseline FFA is definitely important before planning laser treatment in macular edema. The obvious patients to recognize here is who have predominantly focal leakage, because they would respond to the focal lasers, and they do well with appropriately applied focal therapy. Now, cases of mixed leakage with incomplete response, so we might have to do a repeat FA and identify the leaking areas and laser to address the microaneurysms, which was very well shown in protocol T, where 40% of patients required rescue laser even after treatment with aflibercept. Now, for patients with diffuse leakage who may not improve on anti-VEGF therapy, second line to either switch to steroid or give additional grid laser. Now, research suggests that microaneurysm mediated leakage, that is a focal leakage, is less responsive to anti-VEGF than a diffuse leakage. So, FA doing fluorescein angiography before and after anti-VEGF demonstrates more rapid resolution if the leakage is diffuse, but may show persistent leakage when it is focal. So, most patients with DME who present with either diffuse or a mixture, they do well with anti-VEGF as the first line of treatment. Now, coming to OCT, which has definitely taken over, especially as far as the treatment algorithms in concern, and definitely helped us to treat a lot of diabetic retinopathy patients to give them good visual outcome. So this gives us a cross-sectional images of each retinal layer, widely used for detecting patterns related to the course and prognosis. So very important to accurately distinguish between these patterns, so that will help us to tailor the treatment strategies and individualize the treatment options. Now, each of these would reflect different disease mechanisms. They also throw a light on the systemic factors that is going on in these patients. Now, we also know that morphology in OCT, earlier we used to talk as spongiform retinal thickening. Now we also call it as diffuse retinal thickening, where we see that the retinal thickness is more than 200 microns in height and in width, with areas of lower reflectivity, especially in the outer retinal layers. Cystoid macular edema, where there is intraretinal fluid accumulation with low reflectivity, intense leakage from capillaries and microaneurysms, which shows cystoid macular edema type. And there could be a taut posterior hyaloid membrane, which is a highly reflective membrane on the inner retinal surface, causing traction. There could be hyporeflectivity between the neurosensory retina and the retinal pigment epithelium, which is a subretinal fluid, and there could be a tractional retinal detachment too. Now, the other important markers which really has helped us to in fact prognosticate as well as help the patients in counseling. So they are presence of intraretinal fluid. So these are hyporeflective spaces in the neural retinal tissue, and this is SRF, when again a subretinal fluid which is between the neural retinal tissue and the RPE, and disorganization of the inner retinal layers, wherein we cannot distinguish, or we are unable to distinguish boundaries between the ganglion cell IPL, the inner nuclear layer and the outer plexiform layer. The others could be presence of hyperreflective foci or the dots or the spots, so which are activated microglial cells. Initially they were thought to be inflammatory debris also. They are less than 30 microns in size. So how do we differentiate this from hard exudates? Hyperreflective foci do not have backshadowing, whereas hard exudates do have. Hyperreflective foci are less than 30 microns in size. Hard exudates are much more bigger in size. And HRFs may not be seen as a fundus lesion or may not be able to appreciate in their initial stages. They are thought to be as precursors of hard exudates too. So here they indicate damaged photoreceptors. Now, very important another marker is the ellipsoid zone disruption, wherein there is extensive photoreceptor cell body damage as seen as loss of layers. Now, presence of large cysts also, so there is less bridging between the inner and the outer layer. So these markers definitely help us to really categorize or patternize the type of diabetic macular edema, so that helps us in planning a treatment or individualizing treatment options for patients. Now, a few studies have also shown the intracystic hyperreflective material, which is presence of fibrin or other inflammatory products within the cyst, and presence of subretinal hyperreflective material like what we see in the AMD or vein occlusions, so wherein there is a hyperreflective material located between the neural retina and the RPE. Now, what is their significance? Again, I would spend some time on this table so that this helps us to find out what is a type of biomarker and what could be their preferred implication and treatment. Now, in a diffuse retinal thickening, where we have sponge-like thickening, reduced reflectivity, loss of the contour noses, it could be mediated by VEGF-mediated inner blood retinal breakdown. Now, the clinical implication would be early DME, so good visual prognosis and high reversibility if it's an initial stage, and anti-VEGF monotherapy if there is suboptimal response, switch agent, and if there is focal leak, which we can do a focal laser or a grid laser. Now, in a cystoid macular edema, here you have cysts, well-defined intraretinal cysts, large hyporeflective cavities. The underlying pathophysiology is chronic leakage and associated with Muller cell dysfunction. So they can present with worse baseline visual acuity, slower response. They indicate chronic disease. Now here anti-VEGF loading doses, early switch or addition of steroids, especially in pseudophakia, we can also think about the implant. Now, presence of SRF. So this is again a hyporeflective space between the neural retina and the RPE, wherein there is preserved outer retina. So what happens here is there is blood retinal barrier failure, pump dysfunction of RPE pump dysfunction, and one important this one is we have to think about inflammation. So that's very important. So SRF can be associated with some inflammation. Clinical implication, paradoxically, they have better visual outcomes, steroid responsive. So initially anti-VEGF, or consider early corticosteroids if there is recurrent or a chronic SRF. Then presence of hyperreflective foci. So we saw about the characteristics of HRF. They are small punctate hyperreflective dots, no backshadowing. They indicate microglial activation, lipid extravasation and associated with again inflammation. So SRF and hyperreflective foci are associated first with inflammatory component. They have a very poor anti-VEGF response. They are markers of chronic or inflammatory diabetic macular edema. So early steroid or combination therapy could work in these cases. Presence of drill. So there is no loss of clear boundaries between the retinal layers. So at the initiation of treatment, if there is presence of drill or a newer onset of drill or increase in drill, definitely indicate a Muller cell dysfunction. This is inner retinal ischemia and presence of neuronal damage. This is one of the poor prognostic markers. Strong predictor of the poor visual acuity recovery, may indicate irreversible and long-standing damage. So aggressive edema control, visual prognosis counseling and realistic expectations. So a thorough counseling of the patient is very important if we find OCT associated with, features of drill in the OCT. Then outer retinal damage, wherein there is ellipsoid zone disruption. So here it indicates a photoreceptor damage from chronic edema or ischemia. Again, limited visual recovery despite anatomical success, but some literature has shown that the ellipsoid zone healing may predict good visual recovery. So here we are treating to stabilize. Over treatment should be definitely avoided and a guarded prognosis to be explained to the patient. And presence of vitromacular phase abnormalities, again there is mechanical traction, worsening leakage. So poor response to injections alone, so we might have to go in for even surgical options also. So these were some of the classification systems which were discussed earlier. Initially we give a great importance to the classification of clinically significant macular edema, the three important parameters that we ask our postgraduates to definitely learn about these things. And as earlier discussed, so for the treatment purpose, we have center involving diabetic macular edema and non-center involving diabetic macular edema. So when we are discussing about the treatment algorithms, so let us now throw light on DME without traction. So if it could be center involving or non-center involving. If it is center, that means central subfield zone is involved. Non-center does not involve the central subfield zone. So the preferred choice of treatment would be injections or laser in a non-center involvement. Now, in a diabetic macular edema, this could be DME with traction. So, we have three different things that we may expect. That is vitromacular traction, epiretinal membrane and taut posterior hyaloid membrane. So, preferred choice of treatment would be surgical modality. Now, management of center involving. So, if it's a treatment naive center involving diabetic macular edema, so depending upon, it's a center involving, so we would directly go in for anti-VEGF agents, monthly intravitreal injections for 4 to 6 months, and then it could be a fixed treatment or a pro-rata basis or treat and extend. So recurrent DME in eyes that develop recurrent macular edema after complete resolution following multiple anti-VEGF injections continue the same treatment if vision continues to improve with a progressive decrease in the central subfield thickness. Now management of non-center involving. So in a treatment naive non-center involving, depending upon it's a good vision or a not so good vision. So in a good visual acuity, observe and follow ups, and an eye should on the systemic factors, other systemic comorbidities, hyperglycemia, hyperlipidemia, hypertension. Those things also have to be dealt into. In a non-center involving diabetic macular edema with not so good vision, focal laser after fundus fluorescein angiography. Now, after center involving DME has been treated, if there is a non-center involving, again with good visual acuity, we will observe and follow up. Then with best corrected visual acuity less than 6/9, we do an FA and treat the focal, accordingly decide whether to go for a focal or a grid laser after FA. Now, those who fail to respond to macular laser can be planned for a repeat treatment with anti-VEGFs. A plaque of hard exudates, most of us would have seen that, so it may deposit the macula close to the fovea, which carries a poor prognosis. Now, OCTA and DME, yes, it was discussed by Dr. Abhishek. So, the basically superficial capillary plexus, deeper capillary plexus, and FAZ metrics can be more easily measured with OCTA than fluorescein angiography. Now, points to remember here. So they may present with diffuse leakage, mixture of focal and diffuse. They do well with anti-VEGF injections. Managing diffuse and mixed diabetic macular edema frequently requires long-term treatment. OCT performed at each injection visit, especially early in the process. So that will help patients require to ensure patients require ongoing therapy. So we would treat until the patient's OCT shows resolution of fluid, vision has improved, and the fovea returns to its expected morphology. So, who are non-responders? So, most common cause can be inadequate treatment, presence of uncontrolled systemic comorbidities. So, FA or OCT should to be done to rule out any ischemia as the cause, and persistent DME and visual acuity less than 612. We can try with different anti-VEGF, switch to steroids. The indications could be responding to anti-VEGFs but difficult to maintain frequent follow-up visits, or a pseudophakic patients who have reached a plateau. So persistent IRF, so we can definitely switch to steroids. And additional laser photocoagulation to treat persistent edema is also possible. Now, role of vitrectomy in DME, especially recalcitrant DME and predominantly vitromacular traction, or tractional ERM or a taut posterior hyaluronic. So, treatment naive PDR with DME, extramacular traction or vision threatening traction involving fovea or a vitreous hemorrhage. So, in a extramacular traction, PRP 2D diameters away from the traction and standard treatment of diabetic macular edema. In a vision threatening traction, it is surgery. In a vitreous hemorrhage, B scan to rule out traction. Traction plus or minus, vitrectomy, traction PRP as much as possible. Now, anti-VEGFs in such situations should be avoided because it can lead to worsening or crunch syndrome. To note here that presence of DME in a proliferative retinopathy, there is an increased risk of incident cardiovascular disease, the odds ratio of about 2.33. Now, these are the major systemic factors which affect. So, now, the role of systemic factors in the management of diabetic macular edema. There are a number of risk factors that are known, but the duration of diabetes and the glycemic control plays the most important role, as well as the renal disease, presence of anemia. Now, role of strict glycemic control and blood pressure cannot be overemphasized. Elevated HbA1c was associated with increased risk of DME. They say that higher incidence of macular edema is associated with higher diastolic blood pressure, and diffuse edema can be seen in patients with cardiovascular diseases, and patients who are both diabetics and hypertensives have 3 times more likely to develop diffuse diabetic macular edema. So inadequate control of serum creatinine and cholesterol levels can have poorer visual outcomes, despite we would have given the good anti-VEGF treatment, good anti-VEGF therapy. Now, the most important other systemic associations is like the expert panel was suggesting glitazones in underlying hematological disorders, idiopathic thrombocytopenic purpura or multiple myeloma, persistent DME can be seen. Now, if there is a bilateral neurosensory detachments at the fovea which is unresponsive, always think about hypertension, anemia and renal status. Now, rapidly progressing DR and DME in blood dyscrasias, complete hemogram with peripheral smear can also be done. Now, other systemic factors, yes, with dyslipidemia, usage of lipid lowering drugs, especially fibrates and statins. So, it has shown to reduce the severity and foveal migration of hard exudates in macular edema. With anemia, it can worsen DME. So, important thing is anemia to be also taken care of. And with renal disease, we can have ischemic maculopathy, massive exudation at the posterior pole, and extensive peripapillary cotton spots. So, if these clinical findings, fundus findings are seen, so we'll have to really rule out renal disease, because that also may add on to the progression of retinopathy. So these neurosensory detachments may be refracted to anti-VEGF at that. So caution while treating with anti-VEGF. So with cardiovascular disease, use of anti-VEGFs, yes, fatal CVDs are more common. So presence of stroke or MI within the previous 3 months, yes, we would definitely avoid anti-VEGFs and going for steroids. And with essential hypertension, presence of neurosensory detachments and retinal thinning on OCT also could be seen. Now, DME during pregnancy, one of the special situations wherein it may regress postpartum. So, visual acuity reduces, usage of steroid implants, and IV anti-VEGFs in pregnancy is definitely not recommended. So, to conclude, it's complex and must be personalized to each individual patient. Very important to optimize the control of systemic factors including hyperglycemia, hyperlipidemia and blood pressure. Anti-VEGF agents definitely have shown to be effective in numerous randomized controlled trials. So in the absence of any treatment efficacy, clinicians must consider switching from one agent to another, and along with that, neuroprotection, antioxidation and other approaches like targeted laser definitely should be considered during the management. New options like port delivery systems, long-acting anti-VEGF agents, novel pharmacotherapies are also available. Multimodal imaging along with the multi-pronged approach is the key. These are my references. And I thank once again the AIOS team for having given me this opportunity. Thank you, moderators and expert panel. Thank you so much.
Thank you, ma'am. Thank you for that very lucid presentation. It was very beautifully and in a true sense of being an algorithm, very nicely broken down for all the postgraduates and fellows out there. Thank you for simplifying it to that extent. We now invite comments from the expert panel. Dr. Aniruddha Maiti, would you please like to give a few words?
I think it was an excellent presentation, madam.
Thank you,
Uh,
sir.
I think previously what we used to do is the algorithm was based on the tomography, the topography of the OCT, like the spongy thickening, the serous detachment, used to treat with the anti-VEGF or steroid, and then the taut posterior highlight and traction detachment involving the fovea, the surgical nade. So that was the only thing. Nowadays, I think we base the treatment on the OCT biomarkers. And apart from the CMT, what we see, as you mentioned, the drill, bone disruption, the large cysts, which are considered to be the negative prognostic biomarkers. So we can actually now explain the patient in a better way. Sometimes when we don't get an appreciated through the biomarkers. And regarding the choice of treatment, as you mentioned already, the hyperreflective foci, not only it is an inflammatory biomarkers where we prefer to give steroid, your anti-VEGF also helps in reduction of this hyperreflective foci. So I think those things are something new and that helps in our treatment algorithm. Thank you.
Dr. Ankur Singh,
Oh,
can we please have some thoughts from you?
yeah, very nicely covered, ma'am. Just for the residents to know, I just want to talk about one point, that is predominantly peripheral lesions. So every resident should understand that there is a terminology which has come up after the advent of ultraviolet field, which is predominantly peripheral lesions. And why it is important to know about them is because the patients who have predominantly peripheral lesion have 4 times risk of progression of diabetic retinopathy, independent to the stage of diabetic retinopathy and other risk factors. At the same time, in a patient, as you have mentioned, that patient who are not responding to anti-VEGF, looking at these predominantly peripheral lesion, which were missed on a conventional 7 EDTRS fundus photography, can help you to identify the cause as well as the site for the release of VEGF if taken care of with the targeted therapy, which might have been missed in a PRP, will take care of DME. Thank you.
Thank you, sir. Dr. Gagan Bhatia, can we please have 2 words from you?
Yeah, Dr. Soumya, nice seeing you again after many years and very nice talk. I think you've covered the topic very well. I think again, coming back to DME, I think we've changed the way that with protocol I first coming, I think we really changed the way we all started treating DME from focal lasers to C pattern lasers to now with anti-VEGF injections. I think very well is elucidated the use of anti-VEGF injections versus steroids in DME. I think yes, I personally do believe that, and one thing that I don't think that switching too fast is really required. I think it's a VEGF-driven disease. We should always start with anti-VEGF agents and then switch to steroids wherever it is indicated or possible. I think there is a very big thing about this, that okay, you need to give an anti-VEGF injection with cataract surgeries and everything, or with Ozurdex. I think the basic thing is that till the time you don't have clinically evident macular edema, which you can see, and also which you can see on an OCT, I don't think it is required to treat. Secondly, I think one thing that I think which you noted, which I would little bit disagree to, is that the treat and extend pattern. I don't think that we use the same terminology for DME as we would use for AMD. I think yes, I would probably say it's a modified treat and extend or a PRN, basically what we use. With DME, we need to understand that every patient is different, and there's not set protocol that we need to follow. Yes, we treat when we see edema, we don't treat when we don't see edema, and at the end of time, you would realize that with your long follow-up, there is a pattern that is emerging with every different patient, and you call it a modified treat and extend. Secondly, I think that as far as SRF is concerned, I think that is something that can be seen in these cases of of DME, and I don't think we need to run around a little bit of fluid also. So over treatment is also not required because, and especially if you see too much of SRF, I think a renal function test and a renal function is extremely important in these cases, and systemic control is very important. I think one of the differences in treating DME versus AMD is that you need to realize that DME is a systemic disease, whereas AMD is a local disease. So I think managing systemic factors along with anti-VEGF therapy is extremely important. Yes, as you rightly said, focal laser is something which is still there and it should be done. And nowadays, doing adjuvant with focal laser and having an anti-VEGF injection also helps us. I think we do have the next talk where we are talking about about the studies in DME, where the role of protocol protocol T and protocol S will also come in. So I think we can discuss that later. But I think it's very well covered. Thank you.
Dr. Thomas Cherian, can you please chime in?
Yeah, Soumya ma'am, I had a feel that I'm back in a postgraduate class. You covered it so well.
Thank you so much, sir. Thank you.
Yeah, just one or two comments here. Pattern recognition, that is how we always go about in diabetic retinopathy, because we take photos, and unlike other specialities in medicine, we don't have palpation, percussion, or auscultation. We just go by inspection. So it is a pattern recognition. And this pattern recognition is actually two-pronged. One is for us, the clinicians, to prognosticate, and the other is for the patient. If we spend some time with the patient initially with these patterns, many a time the patient comes to you saying, "Doctor, I took 8 injections, but there is absolutely no improvement." So then, if we go by your patterns, the same drill and shrum and the taut posterior hyaloids which you showed, they are the good tools for us to explain to the patients. And conventionally, we have always said the tractional macular edemas respond to surgery, the non-tractional macular edemas respond to injections and lasers. But all said and done, once the anti-VEGF is in the market, all of these, knowingly or unknowingly, we treat with injections. And only when the patient doesn't respond to injections, we think of all this, the non-conventional OCT patterns and whether to go in for surgery. By the time we have given so many injections and valuable time is lost. That is a fact with all of us clinicians. Whether we want to operate or not, we always start with injections. So I don't know whether we'll be able to overcome that urge to give injections in every diabetic macular edema, but then these pattern recognitions take us a long way in deciding and prognosticating diabetic retinopathy and diabetic macular edema. Thank you.
Thank you, sir.
Thank you, sir. Thank you very much. Thank you, Dr. Soumya, again for that very enlightening talk. I now request Dr. Hitashri HR to please share her screen and get ready for her talk on studies in diabetic retinopathy and newer treatment modalities, a much needed, very important topic for all postgraduates and fellows. Thank you, ma'am.
Good evening, everyone, and thank you for inviting me for this AIOS GuruSangam talk. I'll be sharing my. Am I visible? My presentation is visible.
Yes, ma'am, all good.
Yeah, good evening again, and I thank AIOS and all the faculty for giving me this opportunity. My topic today is diabetic retinopathy trials and newer modalities of treatment, no financial disclosures. So why is this diabetes so important? Because it is a global epidemic, and it's growing global epidemic. And 3 in 4 adults with diabetes live in low middle income countries like India. And the estimate for 2045, we have 738 million diabetic patients. Just a second. Where PDR is expected to be 23 million people. So let's start with the diabetic retinopathy trials. Starting from early 1970s to 2025, I think it's almost more than 50 years of trials. So I won't be able to cover everything. Let me just try to cover how much ever possible. So we can divide like trials related to epidemiology of diabetic retinopathy, trials related to classification and management of diabetic retinopathy, and the most important DRCR-NET, Diabetic Retinopathy Clinical Research Network. So coming to these trials with the epidemiology, we have DCCT, Diabetes Control and Diabetes Control and Complication Trials, and UKPDS, United Kingdom Prognostic Diabetes Study. So, which were done in type 1 diabetes and type 2 diabetes, where they found that optimal glycemic control, that is HbA1c less than 7%, is by far the most important factor in the systemic management of diabetic retinopathy. And further, we have ACCORD and accordion that were for the cardiovascular risk factors, and where they found that further intensive control of HbA1c was associated with increased mortality, though it reduced the diabetic retinopathy progression. So then we have trials related to classification and management of diabetic retinopathy. DRS, starting in the early 1970s, 1972, it checked where xenon was used and argon was used for photocoagulation, where it was used in proliferative diabetic retinopathy and severe NPDR cases, where they showed that PRP reduced the severe vision loss by more than 50%. And then we have ETDRS in 1980s, where it extended the treatment for all the whole from mild NPDR up to proliferative diabetic retinopathy, and also treatment for diabetic macular edema. And also it checked whether aspirin had any role in control. And there they checked that focal laser in diabetic macular edema, it reduced the macular thickness and also moderate vision loss rate. And early laser was not indicated in mild or moderate NPDR. So this is just to show focal laser and grid laser that was advocated for focal and diffuse macular edemas. So conclusion for these studies was that over the past 4 decades, when the mainstay for treatment for proliferative diabetic retinopathy and diabetic macular edema were laser photocoagulation, like PRP for PDR and focal or grid lasers for diabetic macular edema, until the era of anti-VEGF therapies. So that time the PRP was shown to destroy ischemic retina, thus reducing production of growth factors that promote the disease progression, such as VEGF, and it reduces the oxygen need. Collectively, these changes caused regression of existing neovascular tissue and prevented progressive neovascularization. Though we have come to the anti-VEGF era, still the recommendations for high-risk proliferative diabetic retinopathy and for even DME, laser still holds good. But other classifications are not being used for ATDRs like CSME, and those things are not being used now. Diabetic retinopathy vitrectomy study, again starting in 1980s. So it studied the natural course and role of vitrectomy on severe proliferative retinopathy. So where they concluded that early vitrectomy is useful in type 1 diabetics with vitreous hemorrhage and poor vision. But they showed that early vitrectomy may not be beneficial, and if it is beneficial only if extensive scatter laser has been done in severe active neovascular proliferation, where there is not much VH or there is only moderate VH. But then we have to look at these results of DRVS in those times where there was still not much advanced vitreoretinal surgery equipment or the small gauge vitrectomy technology, endo lasers, advanced instrumentation. So now we have early versus delayed vitrectomy for vitreous hemorrhage secondary to PDR, which was published in 2025, which says that the mean weeks of early treatment was 3.6 weeks, and by it showed that at 12 months, early pars vitrectomy patients had better BCVA, where the BCVA, baseline BCVA prior to vitrectomy was similar in both groups. So coming to DRCR-NET, which is the most important trials we need to cover. So that is starting from 2002 to present. It's a collaborative network dedicated to facilitating multi-center clinical research of diabetic retinopathy, diabetic macular edema, and associated conditions. It supports identification, design, and implementation of multi-center clinical research initiatives focused on diabetic diabetes-induced retinal disorders. Principal emphasis is placed on clinical trials, but epidemiologic outcomes and other research may be supported. So this is the DRCR network website. You can see all the studies that are being done, which have been done. All the reports can be downloaded. Coming to the specific few protocols we can discuss. So in non-center involving DME, DRCR results, we have protocol B, where they checked that over 2 years, focal or grid laser for DME has fewer side effects than 1 mg or 4 mg doses of intravitreal triamcinolone. Protocol E, in DME with good visual acuity, they found that peribulbar triamcinolone alone would not be effective. The conclusion was that for non-center involving DME, focal or grid laser is better. And protocol R, where topical nepafenac was used in eyes with good vision and non-central DME, they found that it has no effect on the retinal volume in non-central DME. Coming to in center involving DME, protocol I, this was done in the background where at the time of study, anti-VEGF was used for AMD. Focal or grid laser was standard of treatment for diabetic macular edema. And a few studies had already reported intravitreal steroids for diabetic macular edema. So here they concluded that intravitreal ranibizumab with prompt, that is prompt laser, PRP, or prompt focal or grid laser, or deferred after 24 weeks focal or grid laser, it was equally effective to improve visual acuity in center involving DME than laser alone, grid or focal laser alone, or intravitreal triamcinolone at 1 and 5 years. And need for injection decreased over 5 years. So protocol I clearly established the role of intravitreal anti-VEGF as the first line of treatment for center involving DME. Protocol T, one of the very important protocols, it compared the 3 anti-VEGF agents which could be used for DME: aflibercept 2 mg, bevacizumab 1.2 mg, ranibizumab 0.3 mg. And 1 year and 2 year visual acuity changes from baseline visual acuity were checked. In like 3 groups: aflibercept versus bevacizumab, aflibercept versus ranibizumab, bevacizumab versus ranibizumab. And the regimen was monthly injection for first 6 months, unless the BCVA was 20/20 and the OCT was less than 250 microns. After 6 months, PRN based on the BCVA and OCT. Visits were every 4 weeks in the first year, 4 to 16 weeks in the second year. So starting at 6 months, focal or grid laser was allowed if DME was persisting or it was not improving. The principles that were followed were for DME treatment. If the first thing, if it was improving on OCT or visual acuity, OCT, that is central subfoveal thickness, reduced by more than or equal to 10%, or visual acuity letter score improved by more than or equal to 5, then you inject the anti-VEGF injection. Or if there is a worsening seen on OCT or visual acuity, you inject the anti-VEGF injection. Or if it is stable, that is not improving or worsening after at least 2 consecutive previous injections, then anti-VEGF was injected only if the duration was less than 24-week visit, and if the central subfoveal thickness was more than 250 and visual acuity was worse than 20/20. Otherwise, they would defer the injection. So from that, the subgroup analysis, where baseline visual acuity was worse than 20/40, they found that at 1 year, aflibercept did better than the other two, that is ranibizumab or bevacizumab. At 2 years, aflibercept did better than bevacizumab, but not ranibizumab. And bevacizumab didn't do better than either of the two at 1 or 2 years. So while both aflibercept and ranibizumab were similar by 2 years, but then aflibercept, the visual acuity recovery was better and was earlier than ranibizumab. And also the area under curve was better with aflibercept, which means maybe the means of visual acuity over this long duration was found to be better with aflibercept. And the earlier visual acuity by 1 year definitely improves the quality of life in these patients. And when the baseline visual acuity was better than 20/40, when it was better than 20/40, they didn't find much significant difference between the 3 injections at 2 years. And there were no significant differences among the study groups in rates of any serious adverse events or cardiovascular events. Protocol AC, where aflibercept monotherapy versus start with bevacizumab and switch over to aflibercept. This groups were compared. Beginning the switchover could happen at 12 weeks or later. So they found that both groups had similar effects by 2 years again. So it could lessen the economic burden in few population if they could start over with a bevacizumab, and they could be switched over to aflibercept. Protocol U, where it was a short duration study done for non-resolving diabetic macular edema, even at 6 months when they were not resolving. So they tried the adjunctive steroid implant along with ranibizumab. The implant, the dexamethasone implant was given, and they found that it significantly reduced the central macular thickness, but it did not show any change, any benefit with respect to visual acuity. But it may be beneficial in some pseudophakic DME patients. So DRCR protocols and PRP for PDR, protocol F, where PRP versus in one sitting versus PRP done in 4 sittings were compared with respect to central macular thickness and visual acuity changes. PRP can be done in one sitting was their conclusion. And with multi-spot lasers, PRP in one sitting is quite effective and safe. Coming to protocol S, where it was PRP was compared with the injection ranibizumab plus deferred PRP for proliferative diabetic retinopathy cases, where intravitreal ranibizumab 6 loading doses were given and followed up with deferred pannitolin photocoagulation was done in this group. So they concluded that intravitreal ranibizumab was as good as PRP at 2 years for PDR patients in terms of visual acuity, but only thing was the patients had to be really compliant. No substantial safety concerns were seen, and it may be preferred first-line cases in PDR cases with DME. But intravitreal ranibizumab is to be avoided in cases with traction. Also, there was this clarity study where PRP versus aflibercept studied in PDR. It reduced, it also stabilized and maintained till 1 year, but again, close follow-up is needed. Coming to protocol B, that is intravitreal aflibercept versus laser versus observation in patients with center involving DME and with very good visual acuity, more than 20/25. So only one eye were selected in these patients with visual acuity better than 20/25. The main outcome measure was visual decline of more than 5 letters at 2 years. They found that there was no difference in visual acuity between the two groups. So these are few cases from the study where they just observed these cases because the visual acuity was better. And by 2 years, the visual acuity it improved to 6/6 with good systemic control. So conclusion was that central involving DME with good baseline visual acuity need not be treated. They can be observed. Such patients can be observed, but if visual acuity in such a patient would decline during follow-up, he or she may be shifted to intravitreal aflibercept with no negative impact on the outcome. The patient's symptoms are also to be considered. And coming to protocol W, that is intravenous anti-wedge treatment for prevention of vision-threatening diabetic retinopathy in eyes at high risk. 4-year findings from protocol W show that patients with non-proliferative diabetic retinopathy gain no visual acuity benefit with early anti-wedge treatment. So from these protocols, the treatment for diabetic macular edema, the conclusion was that non-center involving diabetic macular edema, the better is to go for macular laser, focal or grid laser. And if there is center involving diabetic macular edema, where visual acuity is better than 6/9, or you can go for observation in such patients. And if the visual acuity worsens or central retinal thickness increases, go for anti-wedge therapy. And in center involving diabetic macular edema, where visual acuity is worse than 20/30 or the central retinal thickness more than 250, you can go for anti-wedge therapy. So DRCR protocol for first generation of these anti-wedge recommendations, we have 4 to 6 monthly injections to be given. Injections can be withheld after 4th month if vision is 6/6 or the macula is dry, or no further improvement seen for the past 2 consecutive injections. That is, after 3 injections at 4th month, if CST is less than 320 for men or 305 for women on Heidelberg, treatment may be withheld starting at 4th month. At 6th monthly visit, if stability is achieved in vision or central subfoveal thickness from the previous 2 or more visits, or if the DME has resolved, further treatment may be withheld. So coming to the newer second generation anti-wedge trials, in patients with DME, we have faricimab, the trials Yosemite Rhine, where it is comparing with aflibercept 2 mg every 8 weeks, faricimab every 8 weeks, or faricimab treat and extend. So it has shown comparable outcomes with BCVA gains and central subfoveal thickness improvement, and with fewer injections over 2 years. Also, aflibercept 8 mg has been compared with aflibercept 2 mg 8 weekly and 8 mg 12 and 16 weekly in photon study. And this has also shown BCVA gains and central subfoveal thickness, comparable outcomes, and fewer injections over 2 years. Another newer molecule, brolucizumab, Kestrel and Kite studies, where it has shown superior drying effect and better visual acuity improvement, and interval between the injections to be extended to 12 to 16 weekly. So summary of this anti-VEGF evidence, we have aflibercept in the first generation, which is strongest when the baseline visual acuity is poor, that is by protocol T, and faricimab is offering longest durability up to 16-week duration. Brolucizumab showing superior drying effect, but there is a small question of intraocular inflammation, and anti-VEGF remains the first-line therapy for center involving DME. So every patient is different and needs customization. We can go with the center involving DME, 3 to 4 monthly anti-VEGF injection, then go ahead with PRN. Anti-VEGF 3 to 4 monthly, followed by macular laser after if macula is dry. Can also be macular laser can be done, focal grid laser. Whenever there are refracted DMEs, we can go for FFA guided macular laser for leaking microaneurysms that might be seen, or switch over to steroids. And non-center involving DME, better to go for focal laser. And whenever vitreomacular traction is present, we have to go for vitrectomy. Here are a few of the just few examples of diabetic macular edema treated with intravitreal anti-VEGF and a very good response with improvement in visual acuity. This was a diabetic patient with reduced vision and persisting macular edema even after 3 doses of anti-VEGF, which responded to intravitreal DEXA implant. And non-center involving DME, initial FFA is better, and then to go ahead with a focal laser, and the patient responded very well. This is one of the cases where we are seeing few of the biomarkers, drill and hyperreflective foci. Even though it was treated with anti-VEGF, but the visual acuity and the response was not like the previous cases. So biomarkers are not still the deciding factors for selection of treatment, but they do help us to prognosticate. And also you can switch over to steroids with very much of high reflective foci, or sometimes the brolucizumab has shown to reduce few of the hard exudates and few of the markers. But they're still not the, this is how the treatment goes for this biomarker. So another case here we are seeing on the OCT that there has been vitreomacular traction. In this case, any anti-VEGF injection or steroid is of no use. So this case needs to undergo vitrectomy. So coming to a few more advances in the advanced laser modalities now. We have Pascal, that is 532 nanometer laser delivered in a predetermined pattern in the semi-automated method. It is faster, less painful, and it is more precise to the condition. And we have Navilas, where live tracking of the eye and live color fundus imaging, red-free imaging, infrared imaging, FFA can be fed into the system, and the physician will be controlling the laser application, and the pre-positioning the laser beam and all that is controlled by the Navilas system. Micropulse laser, where laser is delivered with a train of repetitive short pulses, typically 100 or 300 microseconds on and 1700, 1900 off for DME. This treatment has advantage at xanthophyll, that is 577 nanometer. This can be used where pigment which is located in the inner and outer plexiform layers of the macula, which absorbs the yellow light only minimally. So treatment near the fovea is also relatively safe. And we have selective RPE therapy, where this light is strongly absorbed by the melanosomes in the RPE. And this repetitive pulse of this laser application will selectively damage the RPE due to formation of small cavitation bubbles. And subsequent RPE proliferation and migration restores continuity of the RPE layer. This doesn't show any visible changes in the retina. And coming to some newer trends in diabetic vitrectomy, we have sutureless vitrectomy, 25 gauge, 27 gauge, 25 plus, 27 plus gauge vitrectomy cutters, which help us in better dissection and giving better outcomes. Bimanual surgery is possible with the addition of a fourth port, which a chandelier light can be used, and both the hands can be used for like a forceps and cutter. Like you can see, you can hold the membrane and use the cutter. And also PPV with ILM peeling can be done in diffuse DME patients. We have pre-op adjuncts, that is anti-veg. Anti-veg, any anti-veg that is given pre-operatively for a TRD patient where there is a very florid proliferation of neovascularization to prevent intraoperative a diffuse bleeding, which can be given 3 to 1 week prior to the surgery. And intraoperative adjuncts, we have triamcinolone and perfluorocarbon liquids. Triamcinolone can be injected, which strains the vitreous well and even the membranes well, so it helps in a better dissection. And PFCL can be injected. PFCL can be injected, like you see here, to stabilize the posterior pole while for peripheral membrane dissection, or also now en-bloc perfluoro dissection in TRDs can be done, where PFCL is injected beyond the posterior hyaloid and between the retina for better membrane dissection. And also we have intraoperative OCTs into the microscopes, which help in better dissections during the surgeries. And 3D visualization systems have come, which are helping us in performing better surgeries. And smaller gauge cutters, better fluidics, better and wider viewing systems. These all these are giving us very good outcomes. So you can see here with the preoperative visual acuity, counting fingers over time. With the better vitrectomy, we are able to achieve good visual outcomes. Thank you.
Thank you, Dr. Hitashri, for that wonderful presentation, especially for simplifying and summarizing so many diabetic retinopathy protocols in a nutshell, which can be really confusing. I would now like to invite our expert panel to share their perspectives and any clinical pearls they would like to add.
I think it was an excellent presentation. It's very difficult to cover so many studies in such a short time. As far as the study goes, it's very important and we should be updated with the studies. But practically, when it comes to practice, according to the newer studies, it's like anti-VEGF and anti-VEGF. There is no role of laser at all. That's not true. Even if we give that in DME anti-VEGF after 2 years with a monthly therapy, also there's a lot of patients who will not respond to anti-VEGF. So the ETDRS is still important. We do laser, focal lasers, and protocol A's also actually can't do in our practice. We cannot follow the protocol S. We still do PRP laser in the PDR, high risk PDR. And rather, what we do nowadays is a combination of protocol S and like we do anti-VEGF as well as PRP, as sometimes in the combination therapy. And definitely, this protocol T has helped us to understand which anti-VEGF is better in the patient, the diabetic visual acuity, and we can start with aflibercept. So I think this studies are very important. All studies are very important, but practically we need to see which is feasible in our practice.
Thank you, sir. Dr. Gagan Bhatia, would you like to add?
You're
Very well covered talk. I think it was very good to, I think, cover all these, kind of studies in one go. I think as from a postgraduate point of view, I think I would just like to add that, obviously knowing these studies is extremely important and we need to divide, when you study them, I think it's best to divide them into VEGF studies and into, PRP related study, as Dr. Mehti had also put forward. One thing is that yes, with Protocol T, we've come to know that the newer injections are better. But then I think one confusing thing that comes out of them is that it's not that newer injection works longer. So I think that's not right. They all work the same. When you study these anti-VEGF agents, I think it's important to study their half-life. It's important to study their molar dose. And if you realize the half-life is the same, so it's not like the newer and anti-VEGF are fewer just in 1 or 2 injections. It's basically about, when we study from a study protocol, then there is a tabulated way that you give these injections. That is how these studies work. So yes, practically, if you ask me, as I had said even earlier, I think diabetic disease is a multifactorial disease. So I think we need to, as I think it was even said in the, in the talk, that ascertaining diabetic macular edema with visual acuity is extremely important. So it's not that every or little bit amount of fluid or little bit amount of edema has to be treated. These studies have also shown that early treatment and aggressive treatment earlier on does give better results. The higher, I think one practical tip that I would say, that if somebody is asked that, okay, which injection will you give for a diabetic, please don't come up and please don't say that I'll just give a very higher anti-VEGF because it's going to work better. No, I think in a diabetic, again, systemic disease, we need to see that the patient burden is huge, because they also have other comorbidities, and so I think any anti-VEGF in the beginning would work. So I think we need to differentiate between refractory edema and between chronic DME. That is somewhere that we need to see, and where again the role of FFA comes in, where you know that there is macular ischemia, and it's not that the anti-VEGF is not working and the vision is not improving. It's basically because the macular ischemia is there. So those factors also play a very important role as far as this is concerned. I think surgical diabetic surgery is again a very different paradigm. I think that I don't think I would want to talk about it right now. But I think, yes, going through these studies and knowing what anti-VEGF works where, I think is extremely important. Extracting the role of laser from these studies again is very important. Right. Thank you.
Thank you, sir. Dr. Thomas Cherian, sir, would you like to chime in?
Yeah, Dr. Hithasri, you gave a good overview starting from DRS up to Yosemite, Rhine, and Photon. That was a good overview. But one thing we have to keep in mind when we are practicing diabetic retinopathy is we are practicing in a country like India, where studies help us, they give us good guidelines. But as Dr. Maiti and Dr. Gaganpati has said, studies are not the only driving factors when we treat diabetic retinopathy, because most of our patients, they pay out of their own pockets. Unlike in the West, where many of them have government-supported programs, many of them are insurance-driven. So in India, we'll have to keep the cost of treatment at the lowest for most of the patients. So we should have a good mix of anti-VEGF injections, lasers, surgery wherever needed. But then all these studies are the backbone of what we practice on. So in that way, they are good. But then the patient compliance, the patient's need, all that has to be looked upon. Studies help the postgraduates and the practicing ophthalmologists to tailor-made their treatment protocols. We always base it on scientific foundations. So in that way, it's good, and your talk was well covered. Thank you.
Dr. Ankur, sir, would you like to add?
Yeah, it was a very nicely covered talk by you, Dr. Hitashri. I think you have covered all the important studies, and just wanted to add two things, two important study. One is protocol V. So what does the protocol V tell us? That metabolic control is a very important stuff. So patient who was having visual acuity less than 20 by 25, even they come with a DME, with this little cyst, that patient should be observed and not treated with anti-VEGF. Just the metabolic control can lead to the reversal of these microaneurysms and can treat this DME. However, whenever there is a worsening of the visual acuity beyond 20 by 25, you need to intervene with the help with any anti-VEGF of your choice, depending on the visual acuity. So that could be because if it is worse than 6 by 9, then the choice would be Eylea, but if it is better, then you can choose anyone which you want according to the patient profile. Second important study that which is important to be discussed is protocol AB, that has suggested that when we intervene in the patients with diabetic vitreous hemorrhage early, although the final visual acuity, it's a study between the is vitrectomy and anti-VEGF alone. So intervention early will always help you to achieve a faster visual recovery, which is good in nowadays in patients, but the final visual outcome is almost the same. So just for the the postgraduates when they are giving the exams, the questions are asked that which are the important studies and when to start the treatment, and which are the important studies in vitreous hemorrhage. Thank you.
Thank you all for that discussion. With that, we'll move on to the next topic. It's my pleasure to invite Dr. Vipin Rana for his talk on management of subretinal bleed. Over to you, sir.
Am I audible, sir?
Perfectly well, sir.
Thank you. Good evening, everyone. At the outset, I would like to thank AIOS for giving me this opportunity, and also I would like to thank the expert panels and the moderators for being here and for having me here. So my talk is management of subretinal bleed. We all know that subretinal hemorrhage or the subretinal bleed refers to the blood located between the neurosensory retina and the retinal pigment epithelium, the potential space which is present between these two. So why it is important? It is important because it creates a direct physical and biochemical threat to the photoreceptor's integrity, which leads to the profound and often rapid visual loss. Now, the blood which is present between these two areas comes from where? It comes either from the choroidal circulation or from the retinal circulation. So, in as far as the choroidal circulation is concerned, the blood originates from the choriocapillaries and thus cross a compromised outer blood retinal barrier. For examples, in cases of the CNVM or PCV. In case of the retinal circulation, blood originates from the retinal vessels, dissecting through the retinal layers and reaches the subretinal space due to a compromised inner blood retinal barrier. And example in such cases is retinal arterial macroaneurysm. So let's talk about the etiology. The most common cause of the subretinal bleed is CNVM because of the neovascular AMD. And the other causes which includes is PCV, retinal artery macroaneurysm, high myopia, angioid streaks, Valsalva retinopathy, and trauma. So trauma can lead to the subretinal hemorrhage because of the choroidal rupture, because of the hemorrhagic retinal detachment, or the combined hemorrhagic events. And there are surgery. It can also take place as a result of the surgical complications, for example, in cases of the buccal surgery or in cases of the squint surgery. So whenever patient develops this subretinal bleed, so he presents with sudden onset painless diminution of vision, and there will be central scotoma. So whatever vision he'll be having, that will also be associated with the distortion of the objects, that is a metamorphopsia. So before talking about the signs of the subretinal bleed, let's talk about the basics of the hemorrhage in the eye. So the first one is the vitreous hemorrhage. So vitreous hemorrhage, we all know, is a diffuse hemorrhage within the vitreous, which leads to obscuration of the retinal view. The second one is the pre-retinal, which can be either, sub-ILM or subhyaloid. So subhyaloid bleed will be a board-shaped bleed. It will obscure the underlying retina, and at times you can see a little bit movement with the ocular movements of the ocular movements. You can see a little bit movement of this hemorrhage. However, which is not seen in cases of the sub-ILM, and it is actually difficult to differentiate clinically between the two. However, there are some signs in the literature which has been described. So there's a double ring sign which is described. So the outer ring which is shown in the black arrows is corresponding to the subhyaloid bleed, whereas the inner ring shown in the white arrows corresponds to the sub-ILM bleed. Now, this will be bright red as compared to the other kind of hemorrhages which I'll be discussing. So the second sign which has been described is the arcus retinalis. So it is seen in cases of the subileum bleed. Next is the intraretinal hemorrhages. As we all know that the hemorrhages within the retina, they correspond or they go along the direction of the fibers of the retina. So the superficial if hemorrhages, they are flame shaped, and the deep hemorrhages, they are the dot and blot kind of hemorrhages. Now comes the subretinal hemorrhage. Subretinal hemorrhage will be dark red as compared to the bright red, which was pre-retinal, and we can see the retinal vessels crossing over it, and it will have the irregular borders. Whereas the sub-RP bleed, it will be more kind of grayish in color, and it will have the regular borders as compared to the subretinal. But here also we can see the retinal vessels crossing over it. One more entity which is very important to know is, I think, is peripheral exudative hemorrhagic chorioretinopathy, that is PEHCR, and it is nothing but a kind of peripheral PCV where you can see the hemorrhage in the periphery, and at times it can mimic melanoma. So it is very important to know about this entity and not to get confused it with the melanoma. Associated findings which we have to look for are the drusens, CNVM, disciform scars, hypertensive retinopathy, and the retinal arterial macroaneurysms in the same eye as well as in the fellow eye. Why? Because these things will give us the clue regarding the underlying disease which has led to the subretinal bleed. So diagnostic modalities, we can do the OCT macula, where we can see hyperreflective material between the neurosensory retina and the RP, which corresponds to the hemorrhage. And if it is present under the RP, it will be sub-RP bleed. OCT and angio can detect the CNVM, underlying CNVM. However, it will be limited by the signal shadowing in dense hemorrhages, and same goes for the fundus fluorescein angiography also. ICG can help in cases of the PCV and the pachychoroid disorders. USG-B scan, if I say, it can be done in cases where there is a breakthrough vitreous hemorrhage along with the subretinal bleed. So because there will be no view, so it will be difficult to know whether there is some underlying subretinal bleed or not, because that will change our management. So it is helpful to detect a subretinal hemorrhage in those cases. And now the why treatment is important. What will happen if we leave the submacular hemorrhage as such? So the studies show that intervention is critical, and without intervention, mean final visual acuity often declines to the profound impairment. And studies have shown that nearly half of the untreated eyes lose 6 or more lines of the visual acuity. So it is very, very important to treat the submacular hemorrhage and as early as possible. Why do I say as early as possible? Because of these reasons. So there can be chemical toxicity, that is hemoglobin will release the iron. Iron will lead to the formation of the free radicals, and which will cause toxicity to the photoreceptors and the RP. So this damage can start as early as within 24 hours. Other cause can be the mechanical traction. The clot which forms, the moment it retracts, it leads to the sharing of the outer segments of the photoreceptors. And the third one is the diffusion barrier. When there will be a thick clot between the RP and the neurosensory retina, so the exchange of the metabolites and the nutrients will be hampered, and there will be damage to photoreceptors and the RP. So it is very important to treat it as early as possible. And the prognosis is indirectly proportional to the area, thickness, and the duration. It also depends on the factors like size, duration, thickness, and etiology. So there are various studies which has described it into, or divided into different types. So on the basis of size, it has been divided into small, large, and massive. So small is less than 4 disc diameters. Large hemorrhage will be more than 4 disc diameters, but within the arcades. And once it goes beyond the arcade, it is called as a very large, or you must have heard the term, that is massive subretinal bleed. So massive subretinal bleed is once it crosses the arcades. Most of the studies say that it should be operated within the before the 14 days, and after 14 days the prognosis is bad. So the best prognosis is obviously within less than 7 days, and worst more than 21 days. However, we can see the studies that it has been operated, up to 30 days also, and you may see some better results as compared to non-operating the patient. On the basis of thickness, it can be divided into less than 500 or more than 500 microns. And on the basis of etiology, it can be divided into uh, guarded prognosis or the better prognosis. So guarded can be seen in cases where retina is already compromised. For example, in cases of the ARMD, PCV, where there is already damage to the photoreceptors. The better prognosis will be seen in cases of the Valsalva, RAM, or trauma maybe. So let's understand the evolution of the treatment. Mechanical clot extraction. So before 90s or in the early 90s, the treatment modality was mechanical clot extraction. Either you don't do anything or you do the mechanical clot extraction. That is, go for the pars plana vitrectomy and go for forceps assisted removal of the subretinal clot through a large retinotomy. However, that also leads to the poor results, and patient usually land up in proliferative vitreoretinopathy and recurrent retinal detachment. So the submacular surgical trial, which was done for this, showed that aggressive submacular surgery is not of much benefit, and because of that, there was a paradigm shift from the surgical excision to the pneumatic displacement. So let's talk about the pneumatic displacement, which we need to understand and is very, very important aspect of the management of the subretinal bleed. So in 1996, intravitreal injection of SF6 or the C3F8 along with tissue plasminogen activator was used, and face down head positioning was given for 1 to 3 days. Now, what is plasminogen activator? So TPA, we all know that it helps in this clot lysis. So the some of the some in fact the most of the surgeons, the thought process is or was that the intravitreal TPA, it is not able to penetrate in the subretinal space and is not helpful in the clot lysis. So many went with the aim that they will do only pneumatic displacement with C3F8 and SF6 and will not use the TPA. However, there is one thought process that no, it helps in clot lysis to some extent and should be used intravitreal along with C3F8 or the SF6. So in 2001, Hoppert et al. What they tried is they tried the subretinal infusion or subretinal injection of the TPA along with the 32 gauge rigid cannula. Uh, Remember that nowadays it is the 41 or the 38 gauge cannula which is used nowadays, and most of the PGs, it can be kept in the exam on your that examination tray, or it can be there in the OSCE. So you must know what is the 41 gauge cannula and for what it is used. So after doing the PPV, subretinal infusion of this cannula of this TPA was given, and the fluid exchange here was done. The Martel and colleagues, they came with the novel this idea, that is the combined surgical approach of small gauge vitrectomy along with subretinal TPA plus subretinal air and anti-VEGF combined with fluid gas exchange and chin down position to facilitate displacement of thick submacular hemorrhage of the macula. Now, you know that the anti-VEGF, before the era of the anti-VEGF, it was not given. However, when the anti-VEGF came into the practice, so it has been used in the CNVM, PCV, etc. So when we do the pneumatic displacement, if the cause is underlying CNVM or PCV, it is must to use the anti-VEGF along with that. Why? Because if we don't treat the underlying cause, then the treatment will be something like, mopping the floor with the tap on or not closing the tap. So it will not work, and you will have that thing again and again. And comprehensive study which was conducted by Chang et al. Examined 100 cases of submacular hemorrhage which were treated with PPV, subretinal TPA, intravitreal gas, with or without post-operative VEGF injections. And they found that 82% of the eyes experienced an improvement in the post-operative visual acuity, and approximately 40% of the cases who received anti-VEGF therapy, they demonstrated greater visual acuity uh, 6 months after surgery compared to the group where no anti-VEGF injections were used. Now, this is the table which I could get from one of the articles of American Academy of Ophthalmology, and I think it's very make the thing simplify. So, if there is a subretinal bleed, we have to see whether it is associated with vitreous hemorrhage or not. So, if there is a breakthrough bleed, yes, we have to go for the pars plana vitrectomy. There is no other thought, plus pneumatic displacement with or without TPA. If there is no vitreous hemorrhage, we can perform the OCT or FA or ICGA, or then we have to see whether there is any contraindication to the intraocular gas or not. If there is a contraindication to the intraocular gas, we have to give only anti-VEGF monotherapy, uh, maybe in combination with focal laser wherever applicable. If no, then see whether patient is having contraindication to TPA or not. If there is a contraindication to TPA, use intravitreal anti-VEGF and uh, pneumatic displacement. If yes, then use only intravitreal anti-VEGF and pneumatic displacement. So review the patient on post-op day 1, week 1, and 1 month. And at 1 month, continue the anti-VEGF treatment and add focal laser wherever applicable. To further simplify this, let's talk about this algorithm that if which is based on the thickness and the size of the subretinal hemorrhage. So before saying this, explaining this, just let's remember that intravitreal anti-VEGF, which I have written here, we need to understand that if it is because of the CNV or PCV, we have to give the intravitreal injection. And the other treatment protocol which will be there along with that is, if it is a small and thin, that is less than 300 microns, we can just go for the observations. But if it is small and thick, more than 300 microns, which you feel that it may not get absorbed over a period of time because of the thickness, go for the pneumatic displacement. And if it is large, that is more than 4 disc diameters or thin SRH, then go for the pneumatic displacement or PPV with intravitreal oblique subretinal TPA. If it is large, that is more than 4 disc diameters, or thick, that is more than 300 microns, we can go for the PPV with subretinal TPA or subretinal air. And if there's a total retinal detachment, we can go for the PPV plus retinectomy and the removal of the clot. So it might be looking very, very confusing to all the PG trainees that there are so many protocols and what to follow, what not to follow. I can understand that. But to further simplify that, I'll just show you the few surgical videos that will simplify the things and will make the things very, very understandable. So this is the case 1 where we can see a small subretinal hemorrhage, which is almost less than 1 or equal to the 1 disc diameter. And we can see the OCT also, thickness is also not much. So we'll just observe it. And after 4 days, what we can see is that hemorrhage is completely resolved and the patient has regained vision of 6/9. Case 2, absolutely similar case, but this time it is also of almost 1 disc diameter in size, but this time the underlying cause is CNVM, and previously the underlying cause was trauma. So what we do now? We do now is just give the anti-VEGF and observe, and we can see that over a period of week, the blood is gone. The whatever we can see is the sub-RP blood, and few this SRF which is present. Case 3, this is a medium subretinal bleed. Why do I say this? It is not massive or it is not small, because it is almost up to the 4 disc diameters in size. We can also see a sub of pre-retinal or subhyalite bleed. So what we'll do here, if we observe it will not work, we have to do some intervention. So what do? We will do the pneumatic displacement of this blood. So this is a OCT which is showing this subretinal blood. So how do we do this pneumatic displacement now? So we'll do the AC tab first to make the AC shallow or to decrease the pressure. With 30 gauge needle, we'll inject SF6 or 3 C3F8, which is pure, zero point 0.3 or 0.5. And after injecting, just keep a bud and take it out so that the gas doesn't come out through this place. Once the pressure is okay, you have checked the pressure properly. So this has been done. And now give the patient prone position. And after a few days, what do you see? You will see the air bubble which is inside the vitreous cavity. It will expand with the number of days. And what will happen is the subretinal bleed which was there, it has been displaced because of the prone position and because of the bubble, which has got this displacing effect on the bleed. So you can see the blood is completely displaced. The next is a massive subretinal bleed. So this is massive subretinal bleed. Now, what do plan here? We can't go for the observation. So we have to do some intervention. Here we can see the sub-RP and the subretinal blood. So here I planned the subretinal TPA plus subretinal air. And intravitreal anti-VEGF was given. So 3 25 gauge ports were made at 3.5 to 4 millimeter, and vitrectomy was done. And this is the Kinacor triamcinolone which is being used for PVD induction. We can see the PVD induction. So you do the vitrectomy, and once the vitrectomy has been done, this is a 41 gauge cannula which we are seeing. So with the help of this, I'm injecting the TPA plus subretinal air. So it has been injected, and after that, it just come out and do the partial fluid exchange, not the complete. Remember the partial fluid exchange, air fluid exchange. And after that, replace the air with the SF6. Now, because it is partial, you don't ask the patient to go for the prone position. You have to give propped up position to the patient. So the patient who cannot lie prone, this is also a good surgery for those patients. So patient just needs to be propped up position. And you can see after a few weeks, this hemorrhage is completely gone. And this is what we can see is a sub-RP blood. Sub-RP blood does not get displaced with all these procedures. It usually will remain like this. And subretinal blood is beautifully has been displaced. The ICG was done to see the polyp. And after few months, again, this patient, while being on Eylea only, has developed the recurrent bleed. So you need to remember that once you have done the surgery, doesn't mean that bleed will not come here. Again and again, you can have the this bleed. So you need a strict watch on the patient. Next, second last case. Again, this is a case of subretinal bleed. And this time, what I planned was pneumatic displacement plane. So with the pneumatic displacement, the hemorrhage is beautifully displaced, and patient, you can see the subretinal blood has been displaced. So what I want to say is that it's not that if it is a massive subbleed that you have to go inside and you have to do the surgery only. No, not at all. You can beautifully use the pneumatic displacement at any point of time and try it first. If there is no improvement, this maybe you can go for the other procedures. This patient after 1 year again developed this massive subretinal bleed and was not willing for any other surgery thereafter. This is the last case. Again, massive subretinal bleed. Sorry, quality photo is not well in this. So we can see this time we'll be doing a different procedure. That is only vitrectomy and intravitreal TPA and complete filled with the C3F8. No subretinal TPA and no partial FAX. So this is a vitrectomy which we are doing. And you can see a large amount of the subretinal bleed which is crossing the arcades is present with very significant height of this. So the during the FAX, and 16% C3F8 was used in this. You may or may not apply the sutures. So this is a TPA which is being given. And this is the result after a few weeks. The hemorrhage is completely displaced to the inferior temporal quadrant, even without the subretinal TPA. So it's not that you have to give the subretinal TPA and do this. So it can you can get the results, good results with the other kind of surgeries also. But you should know the different kind of surgeries which are used in the management of subretinal bleed. Thank you so much.
Thank you for that very impressive talk, sir. This very challenging situation of a subretinal bleed, and it was really impressive how you managed to cover everything right from pathophysiology to the many ways in which it can be managed within this limited time. Thank you for that. We now invite comments from the expert panel. Dr. Aniruddha Maiti, would you
Dr.
like to
Bipin,
please say something?
it was an excellent presentation with all types of all the algorithms we have shown.
Thank you, sir.
One, I will just mention this. It is very important to diagnose the sub-ILM bleeding from the sub-highlight bleeding. You have already mentioned clinically how to distinguish, and definitely the OCT also helps. I will just mention one patient of mine had undergone an YAC laser hyalotomy in a case of sub-ILM bleeding because it was not diagnosed. And after 2 sittings of laser, nothing happened. And then this patient was taken for surgery. And obviously, this actually gives a very good results. But the diagnosis is very important, whether it is a sub-ILM bleeding or a sub-highlight bleeding. Coming to the subretinal bleeding, the modalities of treatment, anti-VEGF, now the newer anti-VEGF are very, very potent, and they can actually resolve the subretinal hemorrhage if it is like less than 400 microns. But one thing we need to remember that the blood is very toxic, and when we use this anti-VEGF monotherapy, it takes a long time. So that part, the visual prognosis might be a little bit compromised if we only depend on anti-VEGF monotherapy in some cases. Obviously, if there is an underlying anti-VEGF, we need to give. And the third and the last point I like to mention, the intravitreal TPA, as you showed in your one of the last cases, are sometimes equally effective as subretinal TPA with a less intervention, and it gives a equally good result. There is a lot of studies actually showed that the results are almost equivalent. Obviously, there are pros and cons of each procedure. In the intravitreal TPA, there can be chances of breakthrough bleeding, or the need for the anti-VEGF later on might be more. But in longer, results are almost equivalent to subretinal TPA. Obviously, there will be cases where we can't use intravitreal TPA. We have to give subretinal TPA. But with a smaller dimension of hemorrhage, both are equally effective. Thank you.
Thank you, sir. Dr. Gagan Bhatia, would you please like to?
Yes, Dr. Rana, I think it was an excellent talk and very well covered topic. I think one of my favorite topics also. But I think at a very basic postgraduate level, I think I would just like to say that a few points where I think yes, TPA does work subretinally as well as intraretinally, but we need to remember that it does not work in very old bleeds. So we need to be very careful when we answer that we are going to use a TPA. The second thing is that as far as visual prognosis in subretinal bleeds is concerned, I think you had shown it in your cases that there is a huge difference between a subretinal and a sub-RPE bleed. So any mound, heme mound under the retina does not mean that it is a subretinal bleed. So I think a prognosis in a sub-RPE bleed versus a subretinal bleed is very different. What we are basically tackling is subretinal bleed and not sub-RPE bleed. That is one. So if you have a very thin retinal bleed, I think a very major procedure is really not required. The second thing is that we need to, as you had also covered trauma, I think please don't mix traumatic bleeds with with bleeds which are related to CNVMs. I think in CNVMs, yes, the treatment for basically for CNVM bleed is to shift the bleed from the macular area and then go on treating the CNVM. So it's not just a one-time thing. Secondly, as far as traumatic bleeds are concerned, again, we need to be very careful about traumatic ruptures because that is where choroidal ruptures, where the bleed will come from. And so visual prognosis basically is based on that. So if you can very clearly see a choroidal rupture going through the macula, I think doing a very aggressive vitrectomy in these cases and doing a retinotomy and taking out that bleed is really not required because you ultimately are ending up with more PVR. So that is one. So then second thing is that I think one of the major things about subretinal bleed is that we are basically trying to save the macula. So that is very important. So assessing the macular status is extremely important before you intervene with any of these techniques. So if a question is asked that you have a subretinal bleed, please don't jump and say I'll do a huge retinotomy and I'll put TPA and everything. So it is very important to first assess what is the macular function and what is the status of the macula. If the macula is spared, you don't need to treat that bleed. Okay, so because a large retinotomy again with a very aggressive surgery is again going to lead to more PVR because more exposure of the RP at the end of the day is going to lead to more PVR. So these were the few points that I just wanted to highlight. And otherwise, I think as far as traditional treatment for managing subretinal bleed is concerned, I think it's been beautifully covered, and I don't think there is anything more which needs to be added. Thank you.
Dr. Ankur Singh, would you please like to add?
Dr. Vipin, you have beautifully covered all the management of subretinal and subretinal bleed. All I want to mention for the postgraduates is when you are doing a pneumatic displacement, one thing that is very important is to visualize, is to look at the IOP in the postoperative time. At the same time, you can also see an arterial pulsations when you are planning to do a case of pneumatic retinopaxies, so that the intraoperative IOP is not high. Second thing is this, one thing which is also important is steady and slow injection is important, because another thing that can happen is during pneumatic displacement you are injecting gas. It can the patient can have you can have a fish bubbling, and the fish bubble happens, then the effect of the gas goes away. So in those cases, even if the gas is injected, it is not going to act. So postgraduate needs to understand that the bubble has to be single, has to be large enough, and the IOP has to be taken care of. IOP has to be managed in the postoperative time. If it is high, it has to be taken care of. However, when we do a paracentesis in these kind of patients, usually the intraoperative IOP is usually taken care of. Thank you.
Dr. Thomas Cherian.
Yeah, Dr. Vipin Rana, you brought the entire spectrum of submacular bleeds on the table, and it was well covered. Just one or two inputs which I have to say. One is about trauma. It's a one-time event. So you observe the trauma and it's gone. It might go, or just as Dr. Gagan Bhatia said, it might be a choroidal rupture. Then in that case, you don't have to intervene and it doesn't help. That's fine. But PCV, CNVMs, they are all an ongoing part of an ongoing disease. So those need greater attention and maybe more frequent interventions. Whatever be the type of bleed, whether it's related to PCV or RAM or CNVM, and if it's a subretinal bleed, you intervene, you're giving anti-VEGF or you're displacing pneumatic displacement. Before you do that procedure, always be ready for a VR intervention, because these things could cause a breakthrough bleed. Whatever you do, if it goes away, well and good, but it could cause a breakthrough bleed, and the patient might come the next day with total loss of vision, and you might find a vitreous hemorrhage. That is an easily treatable condition. But then you should be prepared to go in any time when you do these interventions, and the patient should also be prepared accordingly. So that's all I have to say from my side. Thank you.
Thank you so much. Thank you to the expert panel. We now move on to the last talk, but not the least, nevertheless, for the day by Dr. Dipanshu Agrawal on vitreous hemorrhage. I request you to share your screen, sir.
Am I audible and visible?
Yes, sir. All good.
All good. Thank you. Good evening, one and all. Being the last of the lot, my topic for today is vitreous hemorrhage, and at the outset, I would like to thank you guys for giving me this opportunity. So, this is going to the layout of my presentation. We will be discussing vitreous hemorrhage basics, key history points, management plan, and when to treat, when not to treat. So, the basic definition, uh, as per literature, is presence of extravasated blood within a space lined by posterior lens capsule anteriorly, interlimiting membrane posteriorly, and non-pigmented epithelium of ciliary body laterally is defined as vitreous hemorrhage, and incidence is reported long back in literature is 7 cases per lakh patient in a year. So if we have to define, if we have to say as per the definition, vitreous hemorrhage can be labeled intravitreal or it can be pre-retinal. So intravitreal would be anything between the anterior hyaloid and the posterior hyaloid can be labeled as intravitreal vitreous hemorrhage, and the pre-retinal could be subhyaloid, that is between the posterior hyaloid and the ILM, and if it is between beneath the ILM, it can be labeled as sub-ILM bleeding. Relevant anatomy, vitreous humor forms 80% of the globe volume and it predominantly formed by water, collagen, and hyaluronic acid. It forms attachments are multiple at the vitreous base, optic disc, and macula, and also at the retinal vessels. It is an avascular structure. So, whenever a patient presents, clinical evaluation usually presents with sudden vision loss. It is usually acute and painless. Patient can also present with history of floaters, shadows, and cobwebs, and also they can be seeing red hues. So history is very important whenever you're assessing a patient of vitreous hemorrhage. We need to ask the duration of vision deterioration or loss, whether it is spontaneous onset or there is a preceding history of trauma, and systemic comorbidities. Details of these needs to be asked in detail. So, from the history itself and the visual acuity, probably you can assess what could be the possible etiology. If patient has a systemic illness of diabetes or hypertension, it could be due to PDR or vein occlusion. If there is associated floaters or shadows, then patient might have an acute PVD, which has led to vitreous hemorrhage. Then, in both blunt trauma as well as open globe injuries, in ocular trauma cases, vitreous hemorrhage can be present. And in patients with retinal vasculitis with anti-chamber reaction, which leads to pain and redness, there could be that could be the possible etiology. And if patient has there is a history of strenuous exercises in the past, valsalva retinopathy could be a possible etiology. And if there is a history of head injury, then Turson syndrome could be a very well documented. It's a very well documented etiology. Now, if we have to talk about clinical evaluation in detail, then visual acuity is the first thing that we look at. And based on NEI grading, it can be labeled as trace, minimal, mild, moderate, marked, and severe. So this is probably a mild bleed where disc and first all the vessels are clearly visible. Only the area where the heme is, only that part is not visible clearly. Apart from this, could be a moderate amount of bleed where disc and first order vessels are visible. This could be a severe bleed, and this is a marked bleed where no details of the vitreous cavity is seen. So, apart from that, associated features could be a rapid afferent pupillary defect that can be seen in patients with retinal detachment or optic nerve involvement. And if there is a associated rise in intraocular pressure that can be secondary to neovascular glaucoma or ocular trauma. If there is associated neovascularization of iris or angle, that can be seen in patients with proliferative diabetic retinopathy, retinal vein occlusion, or retinal vasculitis. Very important is for understanding of the postgraduate and fellows, important to evaluate other eye. The other eye which does not have vitreous hemorrhage, we lot of time we draw a lot of important clues from the examination of the normal eye, which might not be normal. So, if we have to classify vitreous hemorrhage, we have into various etiologies. The hemorrhage can arise from abnormal vessels, or it can arise from a normal vessel or adjoining structures of the eye. So if the vitreous hemorrhage is due to diabetic retinopathy, this could be the clinical picture. Retinal vein occlusion, it could be secondary to branch retinal vein occlusion or central retinal vein occlusion. And this total media haze could be the clinical picture in these cases. In cases of retinal vasculitis or say in Eales disease, there could be a bleed or fractional retinal detachment due to retinal vasculitis. This is a very important case which I saw a few months back. This was a 25-year-old male. There is no vitreous hemorrhage in this picture, but the other eye of this patient had total cataract. On B scan, there was trace vitreous hemorrhage and retinal detachment. And this eye, the left eye, had a vision of 6/6. But when we examined when we did a dilated fundus evaluation, we could see this C-fan neovascularization, which is very classical of sickle cell retinopathy. So in the other eye, probably this neovascularization has gone into combined retinal detachment state along with vitreous hemorrhage. The other eye was treated, and this eye was treated with panretinal photocoagulation. If we have to talk about vitreous hemorrhage from the normal vessels, then acute PVD leading to a retinal break, which in turn leads to vitreous hemorrhage, is one of the very common causes of vitreous hemorrhages. And because the attachment of the vitreous along the vessels is also strong, and whenever there is a vitreous detachment, it can also lead to vitreous rupture of these normal vessels and in turn lead to acute PVD. In cases of valsalva retinopathy, a sub-ILM bleed is a very commonly documented entity. If we have to talk about vitreous hemorrhage from the adjoining structures, then a normal vessel can rupture, and subhilar hemorrhage post following ocular trauma can be is also documented. And this is a dehemoglobinized blood which is present since past 1 month in this patient. Uh, and this is also very well documented on OCT. And if we have to talk about breakthrough bleed that can happen due to PCV, this is an intraoperative picture where we can see multi-layered bleed. It is usually present in vitreous as well, subhyaloid, sub-ILM, and subretinal bleed. So this, once the vitreous hemorrhage was cleared, this is the clinical picture, how it appears in a patient with PCV whenever there is a breakthrough bleed. If you have to talk about surgical procedures or routine procedures, then probably secondary to trabeculectomy, secondary IOL implantations, or intense retinal lasers could also lead to development of vitreous hemorrhage. So this was based on the structure, but based on the age group. If we talk about common causes of vitreous hemorrhage in children, this could be secondary to birth trauma or retinopathy of prematurity. In middle-aged person, it can be the most common cause being Eales disease. After that, following that, it could be secondary to trauma or acute PVD. In old age, we usually come across systemic disease like diabetic retinopathy, hypertension leading to retinal vein occlusion, wet AMD and PCV as being covered in the last talk, and also acute PVD, which can be lead to vitreous hemorrhage. A small slide about pathophysiology, how hemorrhage absorption is different in general. So whenever there is a bleed in general elsewhere in the body, it is usually it gets extravasated into the blood tissues, and then the polymorphonuclear neutrophils come into the picture and dissolute the fibrin. Fibrinolysis occurs. Within 2 days, the macrophages come and phagocytose the red blood cells, and cellular debris gets cleared. And within 2 weeks, the granulation tissue forms and hemorrhage gets reabsorbed and the scar is formed. However, on the contrary, in vitreous cavity, clot formation is rapid, but fibrin lysis is slower due to lack of this polymorphonuclear leukocyte response. These RBCs, which were elsewhere getting phagocytosed intracellularly, are being lysed extracellularly in the vitreous cavity, and they remain intact for months. That's why you see those old hemorrhages, dehemoglobinized hemorrhages, either in vitreous cavity or subhyaloid space, whenever you examine a patient with old vitreous hemorrhage. The coming to further clinical evaluation, whenever there is a vitreous hemorrhage and you are not able to visualize the fundus, B scan is the gold standard diagnostic modality that one should have, and we need to perform it whenever required. So if there is any low echo reflectivity present, then that could be secondary to fresh vitreous hemorrhage. But if there is old vitreous hemorrhage or blood clot, that we can observe medium to high echo reflectivities. But if there is multiple echoes behind the membrane, that possibly leads to diagnosis of subhyaloid hemorrhage. If there are associated membranes like fibrovascular proliferations or PVD, those associated membranes can be very well picked up. And whenever there is vitreous hemorrhage associated with high spike on retinal detachment, the retinal detachment could be associated. Sorry, the A scan spikes were not available for this B scan images. If we have to talk about few further investigation modalities like FFA, it has a very limited role only when there is a minimal VH and you want to localize the area of neovascularization of CNP areas. And FFA can be used. And MRI is used only when you suspect intracranial bleed secondary to Turson syndrome, and CT for pulling out retained intraocular foreign body. OCT comes into picture whenever there is a subhyaloid or sub-ILM bleed. So to delineate these and to document these cases so that we can compare it pre and post management, this is very important. So to summarize the management part of it, investigation includes B scan, which is the gold standard, OCT in few cases where there is subhyaloid hemorrhage or a sub-ILM bleed, that is basically the pre-retinal bleed. Neuroimaging and FFA has very limited role, and whenever required, we should perform. If we talk about the treatment part, whenever there is a fresh bleed, the patient has presented to you within a day or two of the occurrence of bleed, and there is no associated retinal detachment, you can probably observe the patient for 2 to 3 weeks and then probably intervene depending on what the status of the eye is. Laser therapy is done in usually patients with minimal bleed or patients with bleed secondary to retinal break. So in cases of retinal break, if you barrage the break, and the vitreous hemorrhage would subside automatically. Whereas in cases PDR with minimal bleed, you can start lasering the visible areas of retina. And as you go on lasering the visible areas, in couple of weeks with proper position, the hemorrhage gets settled down and you can probably completely do the laser in the rest of the retina. Anti-VEGF has a very limited role in vitreous hemorrhage. Usually it is given preoperatively whenever you suspect that there is going to be excessive fibrovascular proliferation, which needs to be cut during the surgery. In order to have a controlled hemostasis during the surgery, anti-VEGF needs to be given prior to the surgery, 3 to 5 days prior. And vitrectomy is the current gold standard for treating vitreous hemorrhage which are not getting treated with laser therapy or observation. So I would like to show a compilation of video where I have shown different steps and some important points that we need to keep in mind while we are treating these patients. So first case is of a subhyaloid hemorrhage. There was no vitreous hemorrhage, secondary to PDR. So as you go in with standard 25 3 gauge 3 port pars plana vitrectomy, you can see this hemorrhage beneath the hyaloid space. Once you create an opening, you can go 360-degree and separate the fibrovascular proliferation that is present over the disc. And the hemorrhage gets cleared up very well, and you can cauterize the NVD and laser the periphery. In second case, where the vitreous hemorrhage is there associated with subhyaloid hemorrhage, and there were multiple areas of uh, fibrovascular proliferation and focal attachments. So you go on clearing the vitreous hemorrhage. Then once there is an opening created in the subhyaloid space, the blood loosens up and comes into the vitreous cavity, and you can clear that up with active aspiration. And once the heme is cleared out from both vitreous and subhyaloid space, you can go on and desegment the fibrovascular proliferations that are present. Once you desegment them, then you need to trim them and cauterize them so that they do not bleed post-operatively. You have to trim them to as small as possible to make it a smaller frond and island of fibrovascular proliferation. Once that is done, you can probably laser this retina 360 degree and close the case. In another case where there is a very uh, minimal vitreous hemorrhage but predominantly subhyaloid hemorrhage, this video is shown because you need to induce PVD wherever possible. So temporally there is a traction, but nasally you can induce with active and passive uh, aspiration. And once PVD induced, vitreous hemorrhage gets cleared up, and you can go on lasing the retina. Sorry for the disturbance. Next important step is membrane peeling, ILM peeling. This is done with the help of brilliant blue green dye. Once we inject that, we use an ILM peeling forceps, and I'm using pinch and peel technique to peel the ILM. This is done to remove the already existing ARM if there is any, or to prevent any ARM formation in the follow-up phases, or to remove any tractional component that might lead to macular edema. So pinch and peel is an effective way of removing the ILM in these cases. Once ILM peeling is done and vitreous hemorrhage or subhyaloid hemorrhage is cleared up completely, you can go on to laser the retina. If it is a case of proliferative diabetic retinopathy, you can probably uh, go on to laser the retina 360 degree. And if it is a branch retinal vein occlusion with fibrovascular component extramacularly, or not, the NVE is there, then you can do a sectoral laser. If it is an NVD which signifies global hyperperfusion, then you can do a 360 degree laser. If it is secondary to a break, then you can probably just barrage the laser and settle the retina and put tamponading agent according to the. If there is no detachment, you can very well close the case under fluid, under air, and patients do well post-operatively. If it is associated with retinal detachment, then based on the location of break, you can either inject gas or uh, silicone oil, depending on the case. So, coming to few post-operative case scenario pictures, this was a 56-year-old male, hypertensive. He developed sudden on vision loss since 1 month, and patient was planned for pars plana vitrectomy with membrane peeling, endo laser, and fluid air exchange. Since there was no uh, active traction or retinal detachment, patient did well with closure under air, and this was post-operative 1 month, where visual acuity gain was from hand movements to 6/9 at post-operative 1 month. This was another case of a 43-year-old male patient who had history of trauma, head trauma 1 month back, but he was kept on topical medications elsewhere, and he presented 1 month later. And then in this case, we did following PVD induction, the dehemoglobinized blood could clear up very well. And this was post-operative picture 1 month, where the patient regained vision from counting finger CF to 6/12 post-operatively. This is another case of proliferative diabetic retinopathy. In the right eye, it was associated with vitreous hemorrhage, and in the left eye, it was just simple PDR. So we went ahead with surgery in the right eye, and left eye pan-retinal photocoagulation was done, and patient is maintaining good vision post-treatment in both the eyes. So to conclude, vitreous hemorrhage is a sign, it's not a disease. We need to find the source for it. V-scan is the gold standard diagnostic modality. Observation is safe if there is no retinal detachment, and close follow-up needs to be done. And if it does not resolve within 2 to 3 weeks, then vitrectomy is the we need to plan vitrectomy. Diabetic eyes bleed very profusely, so pre-op anti-VEGF is a good choice, a good option, because it can help you prevent bleed intraoperatively, and vitrectomy works in most of the cases for good rehabilitation. Thank you.
Thank you, Dr. Dipanshu sir, for that excellent presentation. for the management of vitreous hemorrhage with practical decision points. And especially the surgical videos were really nicely demonstrated from a very clear and crisp and a surgical standpoint. I would now like to invite our expert panel for their uh, clinical insights and perspectives before we close this session.
I think all the causes of the vitreous hemorrhage you have covered pretty well and with a lot of nice videos. For the PGs, I would like to mention that the history taking in a vitreous hemorrhage is very important because many a times you can't just see, you have to rely on the B scan, but history will give you a lot of prognostic indicator, like how the patient will do after the surgery if at all the surgery is needed. Sometimes they will give an history of an old RVO, and in those cases, generally they do pretty well. Or you assume that's an acute VVD bleeding, then you need to have a very close follow up because sometimes the bleeding subsides, but they come after 3 weeks with a detachment. So you need a very close monitoring on those patients. And the old age patient, breakthrough bleeding is a very common cause, and in those patients, the prognosis needs to be explained before taking up the surgery. So I think history and the examination on the other eye, which gives a lot of clue what might be the cause of the vitreous hemorrhage. Like in a diabetic case or a ERMD patient, the other eye with a vitreous hemorrhage, it might be a breakthrough element. So these 2 points of history taking and the examination on the other eye is very important in treating the vitreous hemorrhage. It's very vital. Thank you.
Thank you, sir. Dr. Ankur, sir, would you like to add?
Very nice presentation, Dr. Dipanshu. I think you have covered all the indications and all the management of vitreous hemorrhage. All I wanted to say is that something which is important, which I sir has already mentioned, is for the postgraduate is the examination of the other eye. Other eye examination can tell you a lot of things. It can tell you if patient is hypertensive in the other eye. Probably the vitreous hemorrhage that you are seeing in this eye is because of the BRVO. If this patient is diabetic in the other eye, the patient might have an a PDR vitreous associated vitreous hemorrhage. Apart from that, you have rightly mentioned that the gold standard is ultrasound. Do an ultrasound on this patient if you have a bilateral vitreous hemorrhage, and it can tell you the details like is there a TRD. In fact, it can also show you if it is a large retinal tear, the ultrasound can also help you to identify that. So the history, the systemic examination, the other eye examination, and the ultrasound can help you to clinch the diagnosis. And yes, early intervention is always good. And when you know that this patient is diabetic, using anti-VEGF prior and with a TRD, using anti-VEGF really helps you to have a blood-free surgical field and a good post-operative visual outcome. Thank you.
Dr. Thomas Chering, sir, please add your comments.
Yeah, Dr. Dipanshu, that was a very wonderful presentation. And the same points which Dr. Anirudh Maiti and Dr. Ankur said, the only question in vitreous hemorrhage is when to go in or how far can you defer the surgery, because the treatment of management of vitreous hemorrhage is essentially surgical. So do you have to intervene immediately or can you defer it by a few weeks? That is the only question which we have to address. For that, the same 3 points which our experts, Anirudh sir and Dr. Ankur said, the 3 points, one is a careful history taking, second is examination of the fellow eye, and third is a B scan, a careful B scan of the involved eye. That will give you essential clues. And if it is something like a diabetic retinopathy or it's pointing towards vein occlusion, we can probably wait for a few weeks to see for a natural resolution or to prime the patient for the surgery. But if it is a PVD with a vitreous hemorrhage, I would say that you have to go in immediately because along with the PVD, there could be a large tear, and left untreated, that could lead to a detachment. And once a detachment happens, your prognosis is going to change drastically. So that is the only question which we have to address. Otherwise, vitreous hemorrhage has been well covered, and that's all for the postgraduates to take it. Thank you.
Thank you.
Thank you, sir. Dr. Gagan, sir, would you like to add?
Yeah, I think not much is left, but yes, I would like to say one thing is that I think, I mean, most of the things have been covered by the speaker as well as by the panel. I think very good videos. have already been shown. I think the only thing that I would like to say is that yes, when you get a case of vitreous hemorrhage, I think don't just go by the diagnosis, do an indirect of the same eye as well. Sometimes you'll be surprised to see that though there is a vitreous hemorrhage, but on a good indentation and a good indirect, you are able to take a lot of clues, especially in cases where you don't have a very good history or you don't have, prerequisite disease that you can fall back on. So at least in a moderate vitreous hemorrhage, a good indirect goes a long way because you can at least rule out a tear or something if you do have one. The second thing is that I think gone are the days where we would wait for the vitreous hemorrhage to kind of reduce. I think earlier times we used to. I mean, what textbook says that wait for 3 months, 4 months, 6 months. I think those days are gone. So I think early intervention is definitely required, especially for conditions which have been outlined by Dr. Thomas very lucidly. That if you have a PVD, you obviously immediately go in. Secondly, B-scan's role, I think this is one entity where B-scan is still holds very, very true. I think most of diseases are not diagnosed on B-scan now, but B-scan holds a very important role in these cases where you rule out a PVD or you rule out a tear or a retinal detachment. So I think most of the times it would be based on the diagnosis that you need to see when and where you need to intervene, and the modality I think is quite clear, which is mostly surgical. Right. Thank you.
Thank you, sir. And with that, we come to the end of today's session. A heartfelt thank you to all the speakers for their time and efforts, and to our panelists for their guidance and enriching the discussion afterwards. This was a wonderfully interactive academic segment. We will resume tomorrow with session 16 of Retina from 10 a.m. to 1 p.m. Yes, we know it's a Sunday morning, but we promise to make it absolutely worth your while. Thank you, everyone, for joining. Have a good night.
Thank you.
And thank you to the moderators for maintaining the time. You started at 6 sharp and you're closing at 9 sharp. That is wonderful. Thank you.
Thank you, sir.
Thank
Good
you.
night.
Thank you. Good night.
Good night, sir. Good night, everyone.
Good
Thank you.
night.
Everybody.